of sodium and potassium concentration are the most common electrolyte abnormalities found in stroke patients. For the therapeutics, I ordered furosemide to lower her blood pressure and edema associated with her CHF and CKD. It works as a potent loop diuretic, and uh, this inhibition will result in increased excretion of water along with sodium and chloride, magnesium, calcium, hydrogen, and potassium ions. I also ordered her on nicardipine drip to rapidly control her BP. I also ordered enoxaparin for anticoagulant and aspirin as anticoagulant. Omeprazole was ordered to prevent ulcer or heartburn effect of the aspirin, and vitamin B complex and citicoline for neuroprotection. CBC results showed normocytic normochromic anemia with normal leukocyte count, slight elevation of segmenters, normal platelet count. This can be caused by her CHF or obesity or CKD. Coagulation study result prolonged PT, normal INR, normal PTT. For the urinalysis, alkalinic urine, proteinuria, glucosuria, hemoglobinuria, ketonuria, and very high WBC count and RBC count, therefore to consider UTI. Serum electrolytes, hyperkalemia, normal sodium, ECG of 78.95 beats per minute, normal sinus rhythm, upright P wave, PR interval of 200 millisecond, QRS interval of 100 millisecond prolonged, QT interval prolonged at 440 millisecond. Normal axis. However, there is right ventricular hypertrophy and complete right bundle branch block as present in the QRS greater than 120 millisecond and R prime pattern. In the CT scan, there is a loss of gray and white matter differentiation in the occipital lobe, hypodensity between the occipital lobe and the thalamus near the quadrigeminal plate. And here there's a hyperdensity of the basilar artery. Sorry, for the chest X-ray, there is a increased cardiothoracic ratio, impression cardiomegaly. And for the following day, subjective findings regained vision from light perception to normal vision. For the objective, the vital signs were normal with bibasal crackles and reflexes at 3+. For the assessment, cortical blindness secondary to occipital lobe ischemia, secondary to basilar occlusion, secondary to CHF, secondary to CKD, hypertension stage 2 uncontrolled. The plan was to transfer to CCU. Fluid was still IBF PNS to run at 100 cc. However, in retrospect, I should have started her on mannitol. Respiratory, give O2 support to maintain O2 saturation at greater than 95%. Diet, still on CKD diet, and continue monitoring. Diagnostic to the echo to look for cardiovascular structure abnormalities. Therapeutics, nicardipine was discontinued because of the impending hypotension and tachycardia. Lactulose was also ordered because the patient was constipated and continue other present medication. On the third day, there was a restoration of vision, full restoration of vision with BP of 120/80, respiratory rate of 20, autosat of 96, reflexes at 2+. However, still with bibasal crackles with bipedal edema. Assessment, transient cortical blindness, secondary to occipital lobe ischemia, secondary to basilar occlusion, secondary to CHF, secondary to CKD, hypertension stage 2 uncontrolled. Her fluid IB was shifted to HEPLOC, still on CKD diet, continued monitoring, and I requested her lipid profile and HbA1c to check for if there is lipid abnormalities and possible DM. High therapeutics discontinued nicardipine and continued other present medication. Approach to the patient. So for the approach of the patient, we should still follow complete history and thorough physical exam. And the risk factors for this patient are high blood pressure, DM, tobacco smoking, male history, and family history of stroke. So let's review the visual pathway. The visual system begins with the globe, specifically the sclera, uvea, and retina. The retina forms the sensory layer and contains the rod and cone cells, which are your first-order neuron. This specialized neuron synapse with a bipolar cell, your second-order neurons, which relay signals to the ganglion cells, your third-order neurons. The axons of the ganglion cells converge at optic disc to form the optic nerve, which can be subdivided into intraocular, intraorbital, and intracanalicular and intracranial segment. The visual nerves signals leave the retinas through the optic nerves. The nasal fibers carry optical information from the bilateral temporal visual fields and then deposit at the optic chiasm. They combine with ipsilateral temporal fibers. Each optic tract conveys information from the contralateral hemifield of vision. Fibers of the optic tract course posterolaterally around the cerebral peduncles to synapse in the lateral geniculate nucleus of the dorsolateral thalamus. Fibers containing superior visual field information synapse within the lateral LGN, and fibers containing inferior visual field fibers synapse with the medial LGN. Beyond the LGN, the fourth-order neurons transmit visual information through the internal capsule in the form of optic radiations. The superior visual field fibers course anterolaterally through the posterior internal capsule into your Meyer's loop and through the temporal lobe and terminate in the infracalcarine occipital lobe. The inferior visual field fibers course through the parietal lobe along the superior aspect of the lateral ventricle and terminate in the supracalcarine occipital lobe. For the visual field deficits, optic nerve lesion can cause mononocular vision loss. Optic chiasm can cause bitemporal hemianopsia. Optic tract can cause homonymous hemianopsia. Optic lateral geniculate nucleus lesion can cause homonymous hemianopsia. Contralateral temporal optic irradiation or your Meyer's loop lesion can cause upper homonymous quadrantanopia. Lesion in the parietal optic radiation can cause lower homonymous quadrantanopia, and occipital lobe lesion can cause homonymous hemianopia. So what is transient cortical blindness? It is a bilateral lesion of the occipital lobe which can be conceptualized as bilateral hemianopia. The pupillary light reflex are preserved. Can affect both children and adults, and the most common cause of children transient cortical blindness are your traumatic brain injury to the occipital lobe and congenital abnormalities and perinatal ischemia. While in adults, stroke is the number one, followed by cardiac embolism, head trauma, occipital lobe epilepsy, your posterior reversible encephalopathy syndrome, your Creutzfeldt-Jakob disease, and your MELAS. Epidemiology relatively uncommon, and its exact incidence in the general population has not been well studied. For the pathophysiology, the risk factor for cortical blindness includes hypertension, CHF, and CKD. And occlusion of the PCA or distal basilar artery is the most common cause, which can then cause vascular hypoperfusion. And in transient cortical blindness, there is a restoration of blood flow. If the blood flow is restored, disappearance of neurological symptoms with no clinical signs, tapos imaging wala ka ding makikitang lesion na. And if vascular hypoperfusion is not addressed, it can lead to infarction. Other features of visual cortex lesion: Anton syndrome, described as visual anosognosia. Ito yung mga patient na hindi naniniwalang bulag sila kahit alam mong bulag sila. Redox phenomenon, statokinetic dissociation. Here, patients can only perceive moving objects in the blind field, not the static ones. For your Benson syndrome, also known as posterior cortical atrophy, is a form of your atypical Alzheimer's disease. The patient showed decreased visuospatial and vistroperceptual capabilities. For your posterior reversible encephalopathy syndrome, patient presents with acute onset headache, seizures, altered consciousness, and visual disturbance. It is usually seen in association with malignant hypertension and eclampsia. And for your Balint syndrome, it is characterized by simultagnosia, oculomotor apraxia, and optic ataxia. For the management, what is transient ischemic attack? Transient ischemic attack is a transient neurological dysfunction caused by focal brain, spinal, or retinal ischemia without the evidence of infarction. And an event that leaves no clinical or imaging trace of infarction is considered TIA. For stroke, stroke is the sudden onset of focal or global neurologic deficit due to an underlying vascular pathology. In our patient, there is a gradual progression of the symptoms, and there is also mabilis po yung pag-restore ng vision niya, so I considered it transient ischemic attack. In transient ischemic attack, we should exclude common stroke mimickers such as your And precaution, avoid precipitous drop in BP. Do not use rapid-acting sublingual agents when needed. Use easily titratable IV or short-acting or oral antihypertensive medication. On this part, hindi dito nagawa kasi si patient is part of the exemption dito sa rule na to dahil meron siyang CHF. Also, by using this ABCD to diagnostic criteria, meron siyang blood pressure of 140/90, so plus 1, and duration of the symptoms greater than 60 plus 2. Ibig sabihin, this patient has a score of 3, which has a high risk of early recurrent stroke. Therefore, it is reasonable to admit them. For the management, CBC, blood sugar, ECG, PT-PTT, non-contrast CT scan, and for the early specific treatment, aspirin should be given, and for neuroprotection. For the placement of treatment, kasi score niya yung sa ABCD is 3, so nasa hospital na siya. For the delayed management and secondary prevention, the patient was given aspirin, and however, hindi ko pa nagawa na magpa-test for CT angiogram and carotid ultrasound. For the other management, visual training and rehabilitation, restitution therapy, the patient detects multiple light spots on a black screen across blind and normal visual hemifield. On the compensation therapy, compensating for visual loss by saccadic eye movements, and substitution therapy by the use of prism or other devices to project the visual stimulus from the blind side of the visual field to the normal one. For the prevention, risk may be reduced by the management of risk factors, including hypertension, hyperlipidemia, diabetes, and cardiac arrhythmias. For the discharge instruction, final diagnosis of transient cortical blindness, secondary to basilar artery occlusion, secondary to CHF, secondary to CKD, hypertension stage 2, take-home meds of clopidogrel, 75 mg per tablet, aspirin, 80 mg per tablet, 2 tablets once a day for 11 days, then 1 tablet once a day. For the diet, low salt, low fat, low potassium diet, restriction of salt to less than 2 grams, avoid banana, coconut, and potato. Exercise at least 150 minutes per week, distributed at least 3 days with moderate aerobic physical activities with no gaps longer than 2 days. Referral to stroke rehab for visual training and rehabilitation, cardiology department and nephrology department for co-management. Follow up at our institution at 10 a.m. with rush to the hospital if with symptoms of stroke, such as your facial asymmetry, arm weakness, slurring of speech, and we should act fast. My first clinical question is mepivacaine useful in the recovery of patients with cortical blindness? So in this study, I've read a journal, and this include 53-year-old male patient suffering from cortical blindness following bilateral occipital stroke. The intervention was injection of the local anesthetic mepivacaine 54 mg subcutaneously every 3 days, which was compared to mepivacaine and paroxetine. The outcome was the whole right hemifield returned to normal, while hemianopia persisted in the left hemifield, and the effect was transient but reproducible, allowing the patient to lead a normal life. Effect duration increased after adjunction of paroxetine. For the second one, can COVID cause blindness? A 38-year-old male with a case of cortical blindness following posterior reversible encephalopathy syndrome as a complication of severe SARS-CoV-2 pneumonia. The intervention was hydroxychloroquine treatment was stopped, and the dexamethasone was given with a 24 mg per day dosage. And the result was, after the second dose of corticosteroid treatment, patient was able to obey commands and his visual impairment fully recovered. For my last clinical question, how many days should clopidogrel and aspirin be taken for TIA? Patients with acute minor ischemic stroke or high-risk transient ischemic attack enrolled in the POINT trial. Intervention, combination of clopidogrel and aspirin for 90 days compared to your CHANCE trial. The outcome was limiting clopidogrel aspirin use to 21 days may maximize the benefit and reduce risk after high-risk transient ischemic attack or minor ischemic stroke. For the summary of this discussion, cortical blindness is a bilateral lesion of the occipital lobe, which can be conceptualized as bilateral hemianopia. The pupillary light reflex are preserved. Complete and thorough history and physical exam should be performed, and transient ischemic attack should be treated with urgency due to increased risk for stroke. PCA occlusion is the usual cause, and occlusion of the distal basilar artery should also be observed. The management includes treatment of the cause and visual training and rehabilitation. RTPA should be given to patients who met the criteria, and CHF is an established exception to the permissive hypertension rule. And these are my references. Thank you.
Okay, thank you, Jade Moore.
Yes,
Okay, back to your first slide. How many minutes have you got to present? Bilis mo magsalita.
22 minutes po, Doc.
22 minutes, okay lang, sige. So, are there any other questions from the audience? We have questions from the audience? Okay, let's go through your slides first, okay? So, next slide. Okay, next slide. Okay. In the past medical history, you mentioned that the patient is already on dialysis. Were you able to visit when was the last dialysis of the patient?
I forgot to ask the last dialysis, Doc, but on admission, Doc, the following day after admission, she was again on dialysis po.
Yeah, because if a patient is on HD already, when I was reading through the history of this patient, so naka-HD na siya, but I guess that he might have missed session, or it might have been delayed because there was a sudden, the potassium was very high, the creatinine was high, so nagkaroon siya ng parang acute renal failure warranting emergency dialysis. Because if you're on regular HD, your patients don't they don't really suggest you undergo dialysis regularly. But if this patient missed, so that would also be important. So may tatanong si Mama yan. Natanong ko na yun sa Viber group, but for the benefit also of our audience, I'll ask you that later. Dapat alam mo na yung sagot. But yeah, the patient could also have had an acute renal failure, okay, because he missed the dialysis. Okay, next slide, please. All right, so pertinent, you have crackles, you have bipedal edema. Next slide. Okay, where's the lesion? Levelized permotor neuron because?
The deep tendon reflex, Doc, was 3+ po.
Okay, sige. But actually, what are you measuring? Okay, what pathway are you actually testing with your deep tendon reflexes?
Wait lang, Doc. Sorry.
What pathway are you testing when you test for your deep tendon reflexes?
Your somatosensory, Doc?
Your somatosensory? Somatosensory ba? Ano bang affected? Sensation? Motor?
Sa motor, Doc, sorry.
Motor. So what pathway is responsible for your motor function?
Your corticospinal tract,
Your
Doc?
corticospinal tract. Okay. So is there a lesion in the corticospinal tract in this patient?
Wala po, Doc.
Wala. So, let's get forward mo yung slide mo para lumabas yung there's a lesion. Yes. Yes. Obviously, there is a deficit. So, deep tendon reflexes. So, may Babinski din yung patient. So, were you just basing it on the deep tendon reflexes?
Sa deep tendon reflex lang po, Doc.
Okay, sige. Oh, but you did not perform it on the patient, right?
Hindi po, Doc.
This pathway this table that you've seen is atrophy, fasciculation, stone reflexes, DPRs, and your extensor 2 sign, this is actually used more for patients who present with motor deficits. Kasi mas marami kang i-check. Eh yung patient mo naman hindi nag-present ng motor function. Although agree na it's still postganglionic. Okay, upper motor pa rin siya as far as the visual pathway is concerned. Okay, but to say that because of the DTRs, your patient's blindness is due to to use this table. Okay, for your blindness is actually hindi siya masyadong applicable. Pupunta, na-discuss mo naman kasi siya later, no? Pero siguro mas magandang gamitin post-ganglionic, no? Post-ganglionic or post-chiasmatic, pwede din, no? So, or pwedeng hindi siya wala siya sa retina, nandun siya sa visual pathway. Okay, but hindi mo nagawa yung DTRs. This is just a paper case. And there are other, you cannot check kasi for atrophy or fasciculations. Tone, wala naman kasi motor deficit yung patient. Okay, next, lateralize. Okay, bilateral.
Kasi Doc, yung presentation na inano ko is bilateral hemianopia po.
So, bilateral hemianopia. So, where is that? Here.
Doc, pwedeng sa number 7 and pwede rin
number 7. Okay.
Yes po.
Because it's already post-chiasmatic. So, at the level of your optic nerve, your lesions are just, sige, how will you differentiate a lesion in the optic nerve versus if it's post-chiasmatic?
In the optic nerve po, Doc, if there is a pupillary light reflex, post-chiasmatic po. Pero pag wala pong pupillary light reflex, dito po sa optic nerve po.
Optic nerve, okay. Pwedeng nasa eyeball mismo, pwedeng retina, optic nerve. But look here. Wait. Yeah, I'm moving my arrow, but you cannot see my arrow. Okay, look, number 1, total blindness of one eye. Number 2, a lesion of your optic nerve. Okay, we'll just present with hemianopsia on one part in the nasal region. And then at the level of your chiasm, number 3, you have bipolar or hemianopsia or bitemporal. Actually, mas sanay akong gamitin bitemporal. And then number 4, beyond the chiasm already, you already have your homonymous hemianopsias. Okay, can either be full hemianopsia or just a quadrant affected, pie in the sky, pie in the ground, okay, depending on what part of your optic radiations was affected. Okay, but pag sinabi mong bilateral, hinahanap mo yung lesion, hindi yung deficit. Okay? So, lesion, so it's levelized, okay, upper motor neuron, post-ganglionic, post-chiasmatic. Lateralized, lesion ang pinag-uusapan, hindi symptoms. So, the patient presented with, yes, a bilateral homonymous hemianopsia on one side. Okay? So, ang i-describe mo yung position ng lesion. Okay? So, if you look at number 7, sandali, saan ang hemianopsia ng patient mo, right or left?
Doc, bilateral po. Both
right or left?
Yung presentation niya kasi, Doc, is wala siyang makita sa lahat ng visual field niya noon, Doc.
Hindi siya kasi pag sinabi mong hemi, it's just one part, diba?
Yes po.
Okay, sige, sabihin, so you're thinking it's bilateral because both?
Yes po, both the
Alright, okay, sige, bilateral both. So you don't say hemianopsia, diba? Kasi pag hemi, half.
Yes po, Doc.
So you don't say na, ayan, may comment dito si Dr. Manalo. So what if the patient could still see the wall clock and the upper half of space, but could not see the table and the lower half of space before becoming blind? But when she recovered, What if she could see the wall clock in the upper half of space first before seeing the tables in the lower half? Okay, let's just imagine you're looking at a clock. Numbers 1 to 12 na lang. Okay. So, initially, hindi yan nakikita lahat. Tama?
Yes, Doc.
Okay, and then, sumunod, ang nakikita niya na lang ay, kumbaga sa clock, anong numbers?
In 12, Doc.
So, nakikita niya si 12
hanggang sa 3.
hanggang sa 3, yung nakikita niya. Pero hindi niya pa rin nakikita yung
Wait lang. Yung sa baba niya, Doc. Yung
12. From 12, hindi niya pa nakikita. Nakikita niya lang 12 to 3, just that quadrant.
yes, Doc.
Yes? Hindi mo naman nakita yung patient. Kita mo. Anong nakita mo sa patient? Okay. Sige. So, nung nag-recover siya, nakita niya na lang yung upper, so 12 to 3. Okay, pero prior, the entire clock. So you don't use hemianopsia to describe if the visual loss involves the entire, visual field. Okay? You use hemianopsia if it's just one hemi field. Hemi, half. Okay. Sige, next. Levelize, lateralize. Okay, and then, what's the next? Localize to your, occipital lobe. Okay, visual cortex. Sige, next slide. So, infectious trauma, autoimmune, okay, go back please. Metabolic. Okay, what's the most obvious metabolic problem in the patient?
Hindi, Doc, DM niya.
DM ba?
Yung renal, Doc.
Yeah, renal failure. Before hepatic. Although nag-hepatorenal sila pag end stage. Pero renal muna. Okay?
Okay, Doc.
Stroke. Okay, I'm glad that you mentioned press there. So we'll get to that. That's actually my second differential. Okay, next slide. So this one. So aspirin, furo, nicardipine drip. What's your target BP for this case?
Doc, this case kasi, Doc, has a CHF, kaya hindi na po siya finalo with the permissive hypertension po, Doc.
Okay. So what are the exemptions to permissive hypertension?
We have actually 6 exemption po. Your acute myocardial infarction, your congestive heart failure, acute pulmonary edema, aortic dissection, acute renal failure, and hypertensive encephalopathy po.
And which is applicable to our patient?
Under CHF and yun po. Kaya hindi po applicable yung permissive hypertension, Doc.
So CHF, acute renal failure, naisip ko din siya kasi ang taas ng potassium niya bigla. If you're on dialysis, hindi tataas yung potassium mo na ganun kataas. Pwede rin acute, na-intubate yung patient, hindi?
Hindi ko po alam.
Hindi, pero wala ka namang dyan. Wala ka namang setting. So, siguro maganda yung paghinga niya, hindi siya na-intubate, so hindi siya nag-congest. But, CHF and acute renal failure. Sige, next. Therapeutics. You're missing something. Sige, forward. Baka nandun siya sa succeeding slides mo. Okay, and here, can you describe the CT scan?
No? Ay, the CT scan po.
The CT scan? This one?
There is a loss of gray and white matter po, and there is a hypodensity between the occipital lobe and the thalamus near the quadrigeminal plate po. Highlighted on this part po.
Di ba yan?
Doc?
Remove your highlight. Di ba space yan?
Yes, Doc.
Sige. Okay, next slide.
In this slide, Doc, there is a hyperdensity of the basilar artery.
Basilar ba yan? Nasa gilid.
Doc?
Basilar ba yan? Nasa gilid siya. Nasa basilar artery mo.
Wait lang, Doc. Nakikita po ba yung pointer ko, Doc?
Nakikita ko yung pointer, pero yung di ba pang basilar, gitna.
Dito dapat, Doc.
Hindi. Dun space. Hindi, actually, wala ka dyang calcified basilar artery dyan sa image mo na yan. But your basilar artery is midline. So if it's side, can you hazard a guess?
Doc?
Branch is that?
Probably your PCA, Doc.
Okay. It's still calcified. Okay, because you can see it's very hyperdense. Okay, next slide. Okay, so wait, going back to your CT scan, hindi, we're dependent kasi on the cuts. So maybe if we are lucky to have gotten a cut na mas pino, pwede nating mas makita ay ito, sige, wait. Meron ka dito. Sige, nasan dyan yung highlight mo na hindi mo talaga siya masyadong makikita. Okay, sige. Actually, if you're lucky enough, pwede mo naman siyang makita. Yeah, so it's somewhere, yeah, it's in the middle. Your basilar artery should be in the middle. Okay, next slide. Yeah, so but that, I guess that's for PCA because it's to the side. Sige, next. So, basilar occlusion.
Yes, Doc.
Bakit basilar?
Yung una ko kasi, Doc, akala ko PCA siya. Tapos parang part pa rin ng basilar. Kaya kinonsider kong basilar
Sige,
siya.
ano bang branches ng basilar mo? Actually, your PCA is an offshoot of your basilar artery. But if you say kasi basilar, yun talaga yung trunk, no, sa gitna, and you will actually have other lesions, other symptoms, as, sige, pag basilar occlusion, anong kadalasang manifestation ng patient?
Doc? Respiratory distress na po, Doc.
What does your basilar artery supply?
Doc? Yung,
What does your...
May pons na, Doc?
Pons. Okay, pons, which is a part of the?
Midbrain po.
Okay, with the midbrain and the pons are what? Part of...
Midbrain po sa midbrain.
What do you call? Sige. Midbrain, pons, medulla. Together, they are called?
Your brainstem, Doc.
The brainstem. So what symptoms could a patient possibly present with occlusion of the basilar artery? Kung it supplies the brainstem. Actually, meron pa yung mga perforating arteries. Yes, pero kung basilar occlusion kasi, anong deficits mo sa patient? Brainstem ang sinusupply niya.
Nagkakaano na, Doc? Decreased consciousness na po.
Yes. Okay. Is your patient ano?
Hindi po. Yung kinonsider ko kasi, Doc, na basilar siya is before the bifurcation of the PCA. Kaya medyo nasa gilid. Kaya ang inisip ko, nasa gilid yung calcification before the bifurcation po ng PCA. Kaya naging bilateral.
Just before.
Yes po. Yun po yung naisip ko noon, Doc.
Kaya siya ba? Sige, ginawa. Actually, so ang inisip mo na just before nag-bifurcate. So
yes po, Doc.
The basilar, ganon.
Yes po, Doc.
O sige, ano pa ba ang mga lesions na nando? Ay, mga arteries na nasa top ng basilar? So your PCA, they're the bigger ones, right? Pero meron ka pang mga maliliit na perforating arteries doon. Papunta sa?
Yung, ano po ba? Sorry, Doc, hindi ako masyado nakapagbasa doon sa part na yun, Doc.
Alam mo, perforate arteries, diba? Yeah. Paakit, diba? Ang kala mo nasa taas din. So mga So kung iisipin mo kasi siya, nag-basilar, yung just before the bifurcation, affecting both occipital lobes. Pero hindi lang naman PCA yung nasa dulo ng basilar artery. You also have your thalamo perforating. Okay? And if you have lesions of your thalamus, what will the patient present with?
Ano, Dok? Meron kang ano, Dok, visual disturbance pa din pero magkakaroon ka na rin ng loss of sensation po.
Okay. Meron din silang mga
possible na memory deficit po, Dok.
Yes. Behavioral, memory problems. They can also present with decrease in sensorium. Kasi both, and you need, your cephalon is also contributory to is also a part of your ascending reticular activating system. So thalamus din siya doon. So anyway, this patient is fully awake. So mukhang spared si thalamus. So hindi ako masyadong sold sa basilar occlusion mo.
Yes, Doc.
Na nandun siya sa gitna kasi I'd expect a bigger deficit in this patient. Pero baka nag-spasm lang siya. Sige, next slide. Okay, next slide. Okay, next slide. Okay, so here, visual cortex. Sige, next slide. So again, a repeat of the previous slide. Next slide. So transient cortical blindness. So you've mentioned a bilateral hemianopia with pupillary light reflexes preserved. So stroke is the most common. Cardiac embolism, head trauma, occipital lobe epilepsy, press. Okay, next slide. Okay. So in this patient, there was vascular hypoperfusion, but the blood flow was immediately restored.
Yes po, Doc.
Oh, okay, next. Okay, I want to focus more on this press kasi itong iba, hindi siya masyado nakikita. But press, we actually encounter it not so rarely. Okay, in your readings, what conditions present with press?
Doc, usually yung nabasa kong journal is eclampsia po, Doc.
Eclampsia, yeah. So, how does eclampsia present?
Doc, nagkakaroon po kasi ng hypertension pag may eclampsia po. Tapos,
okay.
Ayun po.
So, eclampsia is pre-eclampsia.
Pre-eclampsia po, Doc.
In pregnant women, present with elevated BP. But once they have neurologic symptoms, seizures is one of the most common, it becomes eclampsia. Okay? So,
yes,
natin ang press sa patients with eclampsia. Saan pasyente pa?
Doc, yung sa journal ko kanina is COVID-19 daw po. May presentation ng press po. Press?
Sige, ano pa? Sige, COVID. Sabi ko hindi masyado common, pero common siya ngayon. So, COVID, eclampsia, COVID, ano pa? Saan pa nakikita si press?
Ano, Doc, sa yung mga nagtitake ng tacrolimus and cyclosporin po.
Or
your...
What's pertinent in your patient's past medical history?
And ano po, Doc? Renal failure, CKD po.
And
CHF.
What's the complication of CKD?
Pwede pong ano.
What do you how is the BP of
hyper, Doc?
Okay. Hypertension, chronic hypertension. Actually, di ba, kaya nga si pre-eclampsia, hypertensive pregnant people, women. Tapos kapag you have hypertensive urgency, hypertensive emergency. Hypertensive urgency is actually in the pregnant women is preeclampsia. May nagmamanas din sila, no? Pero kapag nagkaroon na sila ng neurologic symptoms, it becomes an emergency that is eclampsia. But even in non-pregnant women, even in males and other people with chronic hypertension, no, they are also prone to developing PRES. This patient is CKD. So matagal ng high blood siguro, yung uncontrolled ang BP, mahirap pababain yung BP ng mga CKD patients. So pwedeng ang contributory din, no? Others include patients with autoimmune disorders, patients who have undergone transplant and are taking immunosuppressant drugs, no? So yun yung mga cancer, patients taking chemotherapy meds. So yun ang pwedeng makitaan ng PRES. But this is actually my second differential to your case. So I was thinking more of a TIA and then this, because as the name implies, it is reversible. Okay, so once you address the BP, okay, pwede siyang ma-reverse. Alright? Okay, sige, next. Next slide. Okay. Sige, next. Okay, next. So there. What's your ABCD score?
3 po, Doc.
3. So what does that mean? If your patient has an ABCD score of 3,
we need to hospitalize the patient po, Doc, for baka possible kasi magkaroon ng stroke afterwards po.
anong percentage?
That I didn't put on that,
Okay.
Doc. Pero
Risk
ang
of
sinabi lang,
stroke
Doc,
less than in 2 days, diba? Kasi it's good to know. Nilagyan mo na din si ABCD score, pero ano bang cut-off sa ABCD?
ang sinabi lang, ang naalala kong nabasa ko, Doc, is if greater than or equal to 3 yung score, there's a high risk of early recurrence of your ischemic attack. So it is
Okay, so 3 ang cut-off mo.
Yes po.
Okay, sige. So 1 and 2?
1 and 2, Doc, can be managed as OPD po. Pero, ayun po.
Close follow-up. No, actually, this becomes right now, no, we're looking at patients remotely. Not everyone can be brought to the hospital. So this one will guide you as a clinician, whether or not you'll tell your patient to go to the hospital right away or to just wait it out, no? So if your score is less than 3, 2 pala, 2 and below, sorry,
Yes,
then
Doc.
you can advise the patient to wait it out. But unless, it presents with other significant clinical features. Okay, next. So management, all right. Okay, back to your previous, okay, sige. Next slide. TIA within 48 hours. Okay, next slide. Balik. Aspirin for secondary. Okay. This is for TIA. Okay, sige. Next slide. Non-cardioembolic thrombotic. Okay, sige. Next slide. Okay, sige. Next. Okay, wait. The patient is already on aspirin. You still added clopidogrel?
Yes, Doc, because I've read, I've come across a journal po dito po ito po na journal.
Sige.
Ito po, ang nasabi po, the use of 21 days of clopidogrel and aspirin may maximize the benefit and reduce the risk after high-risk transient ischemic attack or minor ischemic stroke po.
Okay, this point trial, kasi in UTIA and minor ischemic stroke, what was the population? What was the patient characteristics in this point trial?
Ano, Doc?
Or sige, anong...
Hindi ko masyadong na i-flash ko na lang, Doc. Okay lang ba?
Sige. Kasi may mga stronger trials, match, charisma, actually, that kind discourage double antiplatelet unless talagang warranted. So in this case, let's see the population. See, look, pero sa taas, may konti lang doon, no? Meron kang increased risk for, go back up. Hindi, patingin na lang muna ako ng abstract. So patients with minor ischemic stroke or TIA enrolled in the POINT trial, combination cost, okay, but increased hemorrhage in comparison to aspirin alone. What year was this published? 2019. Pero meron kasi yung match sa charisma, landmark trials sila for combination clopidogrel aspirin, and they actually supported din naman siya nito na there was higher risk for bleeding. Okay, sige. Balik, baba. Okay? So yung patients mo, method, sige. Were patients, sige, baba. But what was the patient characteristic? We don't usually go for double antiplatelet right away. Okay? We consider double antiplatelet kung kunwari naka-aspirin na yung patient, tapos nag-stroke ulit, di pwede tayo magdagdag. Pero naka-aspirin siya dati, itong patient mo, hindi.
Hindi po, Doc. Wala pa pong
So kung virgin case, usually, so you don't consider aspirin resistance, you don't give double antiplatelet right away. Especially case is CKD. So mamaya magre-report Frances, I hope nasama dun sa slides niya yung Has-Bled score. But you know that this patient at high risk for bleeding, lalo na kung the dialysis yan, nagpa-flush pa with heparin. No, so you don't need to add clopidogrel right away. Pwede siguro in the future kung may second na stroke ulit. Sige, next. But for a virgin case, no previous history of stroke, not on any antiplatelet. Okay, sige, next. Sige, let's go to your clinical questions. Okay, may Pivacaine. Ba't may Pivacaine dyan?
Doc, ano kasi to, nakala ko kasi yung journal noon, na journal reading is anything na connected sa cortical blindness, kaya may Pivacaine po.
Okay, sige. Kasi ano bang alam mo sa Pivacaine?
It's anesthetic agent po siya, Doc.
Okay. This case is a case report, right? It's
Yes
just
po, Doc.
male who presented with bilateral. And why was Pivacaine given to him?
Doc, parang trinay lang nila kasi noon, Doc, the story behind this kasi, Doc, is that yung patient nung binigyan siya ng Pivacaine, nagkaroon po ng rapid resolution of the visual loss po.
Yes, bakit siya binigyan? Was there any other indication? I mean, would you try a drug on someone? Try natin, baka mag-work to. Bakit kaya?
Hindi po nasabi sa case po noon, pero
send na lang nung journal. Yeah, pero kasi parang bilang mo may Pivacaine, walang kinalaman. Sige, may cortical blindness pero may Pivacaine. Tapos pa siya, case report. So hindi siya very strong as far as evidence hierarchy is concerned. So we go more for mga meta, RCTs, yung mga case report, cohort, hindi sila very strong as far as evidence hierarchy is concerned. Pero please send me the journal because I would want to know bakit, alam mo yun, may patient bigyan kaya natin ng Pivacaine, try kaya natin, baka mag-work. Parang there's something missing kung bakit nila naisipan, or was he undergoing treatment for something kaya nabigyan ng Pivacaine, tapos surprise, uy, nakakita siya. Ganun ba yun? Pwede kasi mas ganun usually yung nangyayari. Like patients with pulmonary hypertension were given Viagra. Tapos, biglang meron pala siyang naging secondary effects. So suddenly, Viagra was marketed for something else. Diba? Glutathione being given for patients undergoing chemotherapy. Tapos biglang, pumuputi sila. Suddenly, nagkaroon na ng bagong indication for the gluta. So, aspirin was previously being given for fever, di ba? Pero biglang nakita pwede pala siya for stroke. So, bakit kaya nabigyan ng Mepivacaine tong patient na to? What were they thinking? Sige, next slide. COVID. Ay, hydroxychloroquine yung patient. Sige. But yes, you can present with ano nabasa mo about the press in COVID?
Doc, nagkakaroon po ng Doc, sa autopsy report po nila, it has revealed that like many viral infections, SARS-CoV-2 can cause brain tissue edema and partial neuronal degeneration. Infectious toxic encephalopathy po, nagkaroon po siya ng ganun, and then systemic toxemia, metabolic disorder, and hypoxia contributed to the process of the press daw po.
Was there mention of an inflammatory cascade?
Wala. Ang sabi po sa journal na nabasa ko po, main pathological change lang daw po is brain edema without evidence of inflammation on CSF analysis po, Doc.
Okay. Kasi kung titingnan mo, na wala lang, knowing the usual diseases for press, that present with press, mga immunocompromised, mga undergoing chemo, kidney transplants, kung naka-immunosuppressant, autoimmune. So maybe you know that COVID also does that, also suppresses your, well actually it causes a hyper inflammatory response. Pero yeah, this one's rather new. Sige, next. Next. Okay, ito. So you've already supported it. But point trial, ilang patients yung enrolled?
85 po ata, Doc.
Ha?
Hindi ko po masyadong matandaan.
Sige.
Doc,
okay. Actually, ang mga major trials sa Match, Charisma, Chance. Yun yung mga, ayun pala din pala, Chance try. Sandali, bakit may point ka dyan? Tapos meron kang chance.
Kinompare po nila yung nangyari sa chance trial po, Doc.
Alright. Sige. Pero ganito yung we can combine. Actually, in patients who are at high risk for for clotting, thrombotic events, mga patients na naka-stent, naka-double, minsan triple antiplatelet pa sila. But you'll always balance it with the risk for bleeding. But in this case, since antithrombotic naive, hindi naman naka-aspirin prior, first time na na-stroke or na-TIA, we're good with just one. There's also something missing in your meds pala, take-home meds.
Yes, Doc.
Take-home meds mo, bakit? May kulang ka.
Ay, yung Doc, omeprazole?
Chances mamaya, ha?
Omeprazole.
Hindi. Another, ha?
Ay, yung neuroprotective drugs po, Doc?
No. Sige. Balikan natin kasi stroke din naman yung kay Frances. So, do we have any other questions from the floor? Anyone? Sino bang kasama natin ditong consultant? Wait, I cannot. Okay, is anyone here? Dr. Yagunod is here. Sir, do you have any questions for Jade Moore?
Actually, well, I came in late, so okay. And the next presenter, probably I can be active. I'm sorry.
Okay po, sir. It's okay. Any other consultants? Okay, sige. Alright, okay. Sige, remember this discharge instruction of yours, Jade Moore.
Yes,
And
Doc.
then later, when presents her case, tingnan mo kung ano yung nadagdag dun sa treatment niya. Kasi ito, mild, tama?
Yes
Mild
po, Doc.
PIA. So, nandun siya sa category ng mild stroke. Di pa nga ganap na stroke. Pero yung kay Frances, mas mas nahimo. Sige. Thank you very much.
Thank you po, Doc.
On Frances. And wait, Adrian is raising her hand. Do you have a question, Adrian? Yes, what's your question? Yun.
Hindi po, Doc.
Type mo na lang here.
Clamp po, Doc.
Alam ba yun? Kala ko nag-raise ka.
Applause reaction, Doc.
Sige,
Yes
applause.
po.
Okay, sige. Pinalakpakan ka ng classmate mo, Jane. Sige. So one had the loss of vision.
Applaud po, Doc. Thank you, Doc.
Who's talking now? Are you ready to present, Frances?
Hello po, Doc.
Yes, hello. Okay. Here, bakit parang ang bagal ng boses kanina ni Abelia? Pero ikaw, Frances?
Yes, Doc. Okay na. Saglit lang po, Doc.
Okay. Sige.
So, good afternoon. Hello po. So, good afternoon, doctors. I am clinical clerk Frances Agulay, and I will be presenting a case on cardioembolic stroke with the title Lost for Words. So the objectives of this presentation is for the audience to recognize the importance of a comprehensive history and physical examination of a patient with cardioembolic stroke. Second is to correlate the salient features and diagnostic findings to come up with a diagnosis. Third is to review the risk factors, pathophysiology, and clinical presentations of cardioembolic stroke. And fourth is to know the approach to the diagnostic workup and the management of a patient with cardioembolic stroke. So this is a case of RA, a 51-year-old male who is married and is a former barangay captain at City of Badac, Ilocos Norte. The patient is left-handed and was last seen normal on August 25, 9 in the morning. He came in with a chief complaint of sudden loss of speech. And 6 hours prior to admission, after eating their breakfast, the patient's wife noticed that the patient suddenly was unable to speak. This was accompanied by left-sided body weakness and left-sided facial drooping. Prior to the occurrence of symptoms, the patient took apixaban and losartan. Then, 5 hours prior to admission, due to the persistence and progression of the mentioned symptoms, the patient was brought by the neighbor to the Rural Health Unit of Badac for consultation. The patient was then referred in our institution, hence admission. So for his past medical history, the patient was diagnosed with hypertension and an unrecalled cardiovascular disease last 2019. He was given losartan and apixaban. He has no prior operations, trauma, or accidents. He has no known food and drug allergies. And he was given his first dose of AstraZeneca last June. For the personal and social history, he is a Roman Catholic and is a former barangay captain. He admits of a 14.5 pack year smoking history and is an alcoholic beverage drinker. He does not engage in any physical activities and prefers Ilocano foods. For his family history, his parents had hypertension and there's also a family history of stroke. No diabetes, cancer, asthma, or other hereditary familial diseases were noted. For the review system, so the patient experienced weakness, no fever and chills noted. For the skin, it is unremarkable. For the HEENT, the patient has no head injury, does not use glasses or contact lenses, no eye pain or redness, and the patient has no bulbs. For the respiratory and cardiovascular, it was also unremarkable. For the gastrointestinal tract, the patient had dysphagia. However, no vomiting, jaundice, and abdominal pain were noted. For the extremities, the patient has some varicosities. However, there was no edema noted. For the physical examination, the patient is awake, unable to speak, and not in the cardiorespiratory distress. He has a temperature of 37 degrees Celsius, a blood pressure of 140 over 90 millimeter mercury, a blood pressure of 60 beats per minute, a respiratory rate of 20 cycles per minute, and an O2 saturation of 96 at room air. The patient weighs 75 kilograms and is 1.67 tall with a BMI of 26.9, which is obese according to the Asia Pacific classification. His waist and hips are both 38 inches and with a waist-hip ratio of 1. His skin, there is no cyanosis, pallor, or jaundice noted. The pupils are 2 to 3 millimeters, which are equally reactive to light. He has a pink palpebral conjunctivae and an anicteric sclerae. No eye redness were noted. For the respiratory, no surgical scars or deformities seen. The patient has symmetric chest wall expansion and has clear breath sounds. For the cardiovascular, there is an adynamic precordium, no murmurs, however, regular rhythm was noted and also there is a flat neck pains. For the GIT, the abdomen is flabby, soft, and non-tender. For the extremities, varicosities were noted, no muscle or joint pain, arthritis, or edema. For the neurologic examination, the patient's GCS score is 11 over 15. His NIHSS score was 32, which is severe. His mental status, he is awake, unable to speak, and follow commands. For the cranial nerves, cranial nerve 1 was not tested. Cranial nerves 2, 3, 4, and 6, the pupils were equally reactive to light. There is left homonymous hemianopsia noted through visual threat, and there is a preferential gaze to the right. On cranial nerves 5 and 7, there is the patient has left central palsy. Cranial nerves 9 and 10, the patient was unable to swallow water. However, there are no pooling of secretions, and the patient also has voice hoarseness. And for the cranial nerve 12, there is tongue deviation to the left. For the motor, the left upper and lower extremities is 0 over 5. There is a decreased motor strength in the right upper and lower extremities, which is 2 over 5. For the sensory, no response in the left upper and lower extremities, and there is a decreased sensation in the right upper and lower extremities. For the meninges, there were no pertinent findings. So these are the salient features of my patient. So in order to diagnose the patient, the following questions are asked. First, is there a neurologic problem? So for our patient, yes, there is a neurologic problem. So there are frontal neurologic deficits seen in our patient, which are the following. So second, where is the lesion? So for my to levelize, the lesion is located in the upper motor neuron, since the patient has problem in the cortical spinal tract and the cortical bulbar tract, and no fasciculations were noted. For the lateralization, it is lateralized to the right. For the localization, it is found in the 3 regions of the brain, the cerebrum, brainstem, and the cerebellum. So the cerebellum is found in right frontoparieto-occipital lobes, and for the brainstem in the midbrain, and for the cerebellum in the posterior lobe. Third, what is the lesion? So for my patient, it is probably most likely diagnosis is vascular, since there is an acute onset of symptoms, and the patient has the following risk factors: hypertension, atrial fibrillation, smoking, alcohol intake, and obesity. And he also has a family history of stroke and hypertension. So based on the history and P of our patient, my admitting diagnosis is to consider cardiovascular disease in part in the right MCA, PCA, or right pica and basilar artery, probably cardioembolic, hypertensive cardiovascular disease, hypertension stage 1. So this was the plan on admission. So the patient was admitted to the CCU for neuroprotection. So here our target was to avoid hypotension, hypoxemia, hypo and hyperglycemia, and hyperthermia. So also the following diagnostics were requested: CBC, chest X-ray, CBG or RBS, electrocardiogram, PT-PTT, plain CT scan of the brain, serum bond, creatinine, albumin, sodium and potassium, and to test if the patient has COVID. So yes, the patient was also referred, and this were the findings of these were the results of the diagnostics requested. So first, on the image on the upper left is the chest X-ray on posterior anterior view taken last August 25 with good visualization, in good inspiratory effort, and adequate exposure. So we can see that for the heart, there is a markedly enlarged cardiac silhouette with a cardiothoracic ratio of 0.7, which is indicative of cardiomegaly, and other findings were unremarkable. For the patient's ECG, there is an irregular rhythm with a heart rate of 80 beats per minute, which was calculated by counting the number of QRS complex within 30 boxes. Also, the P waves were not discernible, which is seen on the blue arrows, and there are no PR interval, and there's a narrow QRS complex. For the CT scan, so here on the upper left is the non-contrast axial CT scan of the brain. There are no masses, hemorrhages, or midline shift noted. So we can see on the right side of the brain there is loss of gray-white definition and sulcal effacement noted in the occipital lobe, which is seen in the blue arrow. And in our patient, meron din po kami nakitang hyperdensity in the lentiform nucleus, which could be calcification. So on the right is another CT of our patient. So we can see on the that there's a hyperdensity in the basilar artery and MCA, which may indicate atherosclerosis due to the calcification, the atherosclerotic plaque. So this image the 11th plane. So on the yellow arrow is the MCA, and the red arrow is the basilar artery. Also, there are some calcifications noted in the Sylvian fissure, which is the MCA. There's also hypodensity in the seen on the lower image. Hypodensity in the occipital lobe and the frontal lobe. So for the For the CBC, we can see that the patient has decreased hemoglobin and hematocrit count. The RBC is also decreased, which is relatively common in patients with ischemic stroke due to the fragility or destructions of the cell. For the patient's INR and APTT are within the normal range. So this was the order of our patients in the first hospital day. So the other diagnostics requested were echocardiogram, FBS, HbA1c, and lipid profile. And for the therapeutics, the patient was given apixaban 5 milligrams, rosuvastatin, omeprazole, lactulose, vitamin B complex, and paracetamol. So later in the succeeding slides, I will be showing the rationale for my medications. So this is for the second hospital day of our patient. So for the diagnostics, the fasting blood sugar of our patient was 7 millimoles. His A1C is 7%, LDL 180 milligrams, and total. So with this, based on the diagnostics of our patient, our primary working impression is cerebrovascular disease, infarct, right middle cerebral artery, right posterior cerebral artery, right posterior inferior cerebellar artery, and basilar artery, probably cardioembolic, hypertensive, arteriosclerotic cardiovascular disease, chronic atrial fibrillation in controlled ventricular response, hypertension stage 1 control. So this is the summary of the management given to our patient. So for the therapeutics, my patient was given apixaban 5 milligrams since his CHA2DS2-VAS score is 4 and has blood score is 2. And for the mode of action, so apixaban inhibits the thrombin production and conversion of fibrinogen to fibrin and thrombus formation. The patient was also given captopril 25 milligrams to address hypertension, and rosuvastatin since his LDL was 180 milligrams and total cholesterol was 300. For the regular insulin, wala po siya sa previous na orders, but the patient should be given insulin since his fasting blood sugar and A1C were elevated. The patient should also be given digoxin as a management of atrial fibrillation. Omeprazole was given to our patient with apaxiban to reduce the risk of upper GI bleed, and paracetamol for the prevention of hyperthermia, and lactulose for as preventive and therapeutic option for stroke. So next, so the patient was ordered to monitor the input and output, CTG, stroke scales, NIHS and DCS, neuro vital signs, BP, MA, MAP, respiratory rate, pupil temperature, and BP monitoring and management. The patient was also referred to cardiology since the patient has atrial fibrillation for co-management, and was referred to occupational therapist or speech pathologist to address his dysphagia and dysarthria. And the patient should also watch out for the saturation, loss of sensorium, and signs of bleeding. So for my discussion, cardioembolic stroke is responsible to 20% of all ischemic strokes, and the strokes tend to occur suddenly with maximum neurologic deficit present at onset, and the most common site are the internal carotid artery, MCA, PCA, or one of their branches, and non-rheumatic non-valvular AFib is the most significant cause of cardioembolic stroke. So atrial fibrillation is characterized by disorganized, rapid, or irregular atrial activation with loss of atrial contraction and with an irregular ventricular rate that is determined by AV nodal conduction. So the most common sustained arrhythmia, it is also the most common sustained arrhythmia and is major public health problem. So the risk factors for developing AF are the following. So it's common in men and is more prevalent in older patients: hypertension, DM, cardiac disease, obesity, and sleep apnea. So highlighted are the risk factors present in our patient. So this figure is the pathogenesis of ischemic stroke. So for our patient has cardioembolic stroke due to atrial fibrillation. So in atrial fibrillation, there's an clot formation in commonly in the left atrium, which then travels to the brain and which causes decrease in cerebral blood flow. So what happens is that there's an increased glucose metabolism in the penumbra, causing increased volume infarction, or there is a decrease in O2 and glucose in the infarct location, leading to increased lactate production, causing astrocyte death, and this death will prompt the release of TNF, IF, and interleukins, causing inflammation. And there's also a decreased ATP production, where there is a causing dysfunction of the sodium-potassium pump. And there's also a release of glutamate, causing excitotoxicity, leading to necrosis. And also, the influx of oxygen with sodium causes compression of vessels and tissues, leading to the breakdown of blood-brain barrier, causing secondary inflammation. So overall, this causes symptoms which is specific, which depends on the localization of the infarct or the infarct. So this another figure is the impairment by localization caused by ischemic stroke. So in our patient, our patient has decreased blood flow in the MCA, PCA, and the basilar artery. So in our patient, our patient was aphasic. He also has left contralateral hemiparesis and visual field deficits. He has left homonymous hemianopsia, and also for the PCA, our patient has also contralateral homonymous hemianopsia, and for the decreased blood flow in the basilar artery, our patient has cranial nerve deficits seen, such as dysphagia, tongue division, left face central paralysis, and dysarthria. Also, not mentioned in this slide is the involvement of the pica. So in pica, there's what we call the Wallenberg syndrome. So in our patient has dysphagia and hoarseness. So next is the stroke prevention. So patients with AFib have an average annual risk of 5%. So the risk of stroke can be established by calculating the CHA+DS score, and for patients with non-valvular AF with prior stroke or transient ischemic attack or CHA+DS score of 2 or greater, oral anticoagulants are recommended. And the purpose of anticoagulation is to decrease the thrombus formation and to reduce the risk of stroke or systemic embolism and atrial fibrillation. However, there's a possibility of increased bleeding. So here is the CHA+DS risk stratification score. So in our patient has hypertension, DM, due to his elevated FBS and A1C values, and the patient also has score. So his total score is 4. Next. So for anticoagulation, the following drugs are recommended. We have warfarin, dabigatran, rivaroxaban, and apixaban. So in our patient, we gave our patient apixaban. So apixaban inhibits the thrombin production and conversion of fibrogen to fibrin and thrombus formation. So our patient was given 5 milligrams twice a day. So On the right is the has blood bleeding wrist stroke, which quantify the patient. So our patient has stroke and is currently taking an anticoagulant. So he has a total score of 2. So for my clinical question, so do patients with non-valvular atrial fibrillation taking apixaban have better treatment outcome? So in a cohort analysis by Dietel Wig and his colleagues in 2017, so he compared the risk of stroke, systemic embolism, and major bleeding of elderly who ages 65 or older with non-valvular atrial fibrillation initiating apixaban versus rivaroxaban, dabigatran, or warfarin. So the result of this is that the treatment with apixaban was associated with significantly lower risk of stroke or systemic embolism and major bleeding than treatments with rivaroxaban and warfarin, and trended towards better outcomes compared with treatment with the dabigatran. So these are the figures that which compare the apixaban with other drugs. So the top figures are the analysis of time to any stroke or systemic embolism among matched cohorts, and below is the analysis of time and to any major bleeding among matched cohorts. So we can see that the blue line represents apixaban and the dotted line represents the drugs being compared. So in here, the stroke and systemic embolism and major bleeding were significantly lower during in patients treated with apixaban compared to rivaroxaban and warfarin, and also the major bleeding and stroke and systemic embolism for patients treated with apixaban versus the dabigatran trended to be lower but did not reach statistical significance. So for my summary, so cardioembolic stroke occurs as a result of an embolic occlusion on the cerebral veins, and the clinical manifestations depends on the site of lesion, and emboli from the heart goes most often lodged in the internal carotid artery, MCA, PCA, or one of their branches, and non-rheumatic atrial fibrillation is the most significant cause of cardioembolic stroke, and anticoagulation is recommended in patients with AF to decrease thrombus formation systematically and reduce the risk of stroke or systemic embolism. So that ends my presentation. Thank you.
Okay, thank you, Frances. Do you have any questions from the floor? Dr. Yagono, would you want to ask questions?
Okay. Thank you for including me in your discussion. Francis, okay. What was the mental status of this patient on the fourth hospital day?
Doc, actually, until second hospital day lang po yung update namin for the patient po.
So because the beginning of stroke, that's September, that's August 25.
Yes, po.
You had an initial CT scan which showed not much edema, and therefore the mental status would be okay.
Yes.
But you expect in a massive stroke like that, for example, a right MCA stroke, you expect on the third or fourth day some form of mental status changes, no? So that's the reason why you have to be on guard when you are dealing with a massive stroke like a ICA occlusion or MCA occlusion on the left or on the right. Okay, so maybe a repeat CT scan on the third or fourth day, or maybe he may require what we call emergency decompression surgery, which is a hemicraniectomy, which means that you remove part of the frontal, temporal, and parietal bones to give space for the swollen brain. You know? So you remove that. It's a life-saving procedure. That's what we do as neurosurgeons. Anyway, the question is, okay, so this patient is left-handed, right? And
Yes, Doc.
he has a speech deficit. And you would say that if the patient is left-handed, his dominant brain would be on the right hemisphere, correct?
Yes, Doc.
But in a very small percentage, right? Most of the left-handers, like Bill Gates, Mark Zuckerberg, Steve Jobs, you know, are left-handed. They're more creative, and probably most of them have a right-sided or a left-sided hemisphere dominance, right? So you don't pretend that if you are left-handed, it's automatic that your dominant brain will be on the right side. It's only, I would say, 10% or less, or 10 to 15% of left-handed people have a right hemisphere dominance. Most of them, they have a left hemisphere dominance. So, of course, you have a left-handed, left-sided deficit if you have a right hemisphere stroke, correct?
Yes, Doc.
Okay. So how about the tongue? So the tongue is deviated towards the left side, you said, right? When they stick out their tongue, when the patient sticks out his tongue. Is that correct?
Yes, Doc. It was deviated to the left po.
Or to the left? So you're thinking about a left hemisphere, cerebellar hemisphere problem, correct? So if it's like that, what? I cannot, with the presentation of the patient, reconcile a posterior fossa insufficiency in this patient. So, is there some atrophy on the tongue, if you know?
Doc, I was not able to ask po, Doc.
Okay, so this is a virtual patient. Anyway, so if you look at a patient with a posterior fossa problem, you stick out your tongue, it deviates to the left side, and so you're thinking about a left 12 nerve palsy. When you look at the muscles there, see if there's a fasciculation or atrophy too. So that's a part of your physical examination. So, and then some other cranial nerve problems if you're dealing with posterior fossa insufficiency, facial palsies, for example, thalamic problems, because the supply of the thalamus comes from the medial and posterior thalamic perforators, branches of the PCA and SCA sometimes. So in a way, I enjoyed your presentation, Francis, and
Thank you po, Doc.
if we go further, if we want to go further on this patient, following this patient in the hospital, the most important thing that you have to follow is the mental status. Expect something about what happens on the third or fourth day when swelling starts to happen, meaning increase intracranial pressure starts to happen. Definitely because of the cytotoxic type of edema that a stroke can produce. So you expect some swelling there, and there's a shift of midline, and you have brainstem shift too. So, and then your mental status will deteriorate. That's when it becomes an emergent situation. Okay. Otherwise, That's all I can contribute, Dr. Manalo.
Okay po, sir. Maraming salamat. Thank you po. Actually, very important yung binanggit ni Dr. Liago nun about the handedness and the dominant hemisphere. So most of the time, if the chief complaint is an aphasia, we'd expect the patient's weakness to be on the right side, okay, because it's governed by the left hemisphere. But most right-handed patients are left brain dominant. A small portion of your left-handed patients are right brain dominant. Okay, so most of the time pa rin, pag na-stroke yung left, spared yung speech kung left brain dominant sila. But there's greater percentage in left-handed individuals to be right brain dominant. And this is one of those, no? Hindi tayo, well, we see, pero hindi kasi siya ganun ka-common, no? Okay, sige, let's go through your slides, Frances. Isa-isahin natin, So, he's a barangay captain, took a Apixaban and losartan. So, he's already on Apixaban, this patient.
Yes po, Doc.
Okay, 4.
Ang sabi lang po nung sa history po ay it was taken po kasi may sakit daw po siya sa puso.
Yeah, so malamang chronic AF na to, no? Kung naka-Apixaban siya. Is there a cardiologist on board prior? Was he being seen by a cardiologist?
No po, Doc. Nung sa 2019 po, Doc, nagpa-OPD lang po siya for his hypertension po and was later found out that he also has sakit daw po sa puso.
All right, okay. There are a lot of heart diseases, di ba? CHF, AF, valvular heart disease, rheumatic heart disease. Okay, sige, next. So 6 hours prior to admission, 5 hours prior to admission. So, di na siya candidate for RTPA, okay? Because it's already beyond the time window. Also, if your patient is taking anticoagulants, you need to check the PPINR. The patient is still a candidate if within 3 hours. But beyond 3 hours, at naka-anticoagulant, hindi na pwede. Pero pag less than 3 hours at naka-anticoagulant ka, you test for the PPINR. Okay, so we still follow strict criteria for administering RTPA because, it has a risk of bleeding. It's akin to actually giving snake venom. Okay, so 6 hours, 5 hours prior to admission to the first hospital pa. Okay, sige. Next. Next slide. So past medical, he's on Apixaban. First dose in June. When was this patient admitted?
August 25 po, Doc.
Kailan ang kanyang second dose ng AstraZeneca?
Doc, wala daw pong update.
June, July, August. Kasi September, di ba? Pero kakastroke niya. So will you clear pag bumalik tong patient na to? So what have you read about vaccines? Or if you've attended that, yung post-read ninyo sa College of Medicine where Dr. Lulu Bravo gave a talk, would you clear this patient for his second dose of AstraZeneca? It's a common question nowadays. Frances, are you there?
Ay, Doc.
Yes.
Doc, for a patient, yes po, Doc. A patient the patient can receive po AstraZeneca as his second dose po. But requires clearance po, Doc. Pero yes, he can.
Now, will you clear the patient?
Ay, yes po, Doc. Yes po.
For example, I'm the patient's wife. Naku, nag-first dose siya na, people sometimes they'll think, okay, nagpa-vaccine. Was the vaccine contributory to his stroke? Yes or no? Or how will you be able to convince the wife or the patient to have his second dose na stroke siya pagkatapos ng first dose of AstraZeneca?
Doc, Wala naman pong contraindications po to prevent the patient from receiving the second dose po. And hindi po contributory po yung vaccination to the occurrence of stroke po.
Okay, so actually, AstraZeneca has been implicated in increased blood clots, right? Astra and Janssen. Okay, Astra and Janssen. Okay, but this patient also has risk factors that even without the immunization already raises his risk for stroke. No, so we've encountered many patients now who are hypertensive, diabetic, cardioembolic stroke, so we have AF. And then they took the AstraZeneca vaccine and they had a stroke. And then they blamed the vaccine. When in fact, they are already at high risk to begin with. So yeah, Astra and Janssen, kumbaga, when you, because now we're very aggressive now with vaccination so that we can get back to our normal lives. But many people, you see that many people are scared about it. Especially ito, nag-first dose, tapos nag-stroke. So agree na wala namang association or parang causality. Yes, there is a risk, but it's actually more common in young women. It's more common in young women. Also, the risk for blood clot, after an Astra, I'm not so sure of my stats, but the risk of getting a blood clot after a COVID vaccination is even less than the risk of being struck by lightning. Okay, you actually have higher risk of getting COVID, and COVID can also present with a hypercoagulable state. So maybe parang pag gano'n, you tell the patient, mas mataas naman po yung risk na ma-COVID ka, at pag na-COVID ka, pwede pa rin pong magbara ang ugat. At mas mataas pa rin yun kaysa dun sa vaccine. So risk and benefit ito. I remember from the postgrad, Dr. Bravo said that vaccinology is a new science and these medicines are new. We don't know what their side effects are. Right? But at this point in time, when we're in a pandemic, the goal is just to get out of this alive. So yes, agree with the second dose. Tatanungin kasi sa'yo yan no? Very buti nalagay mo sa past medical history mo na nagpabakuna siya. Okay, food preference, Ilocano food. Na-mention what kind of Ilocano food?
Hindi po, Doc, pero most probably salty foods po.
Salty foods, okay. Gulay, mahilig ba siya sa gulay?
Doc, hindi po na-specify po ng
Hindi
patient.
siya na-specify. Okay, sige, next slide. Dysphagia. Okay, next slide.
Kasi yung information.
Next slide, Frances. Sinaghang ba? Okay, physical examination, irregular varicosity, severe stroke, 1A, 1A0, 1B2, 1C2. Okay, 5-4, 5B. So unable to speak and follow commands. So the patient is unable to speak and is unable to follow commands. Students more equal and reactive with a homonymous semianopia. Preferential gaze to the right. Unable to, okay. Unable to swallow water, no pooling of secretions. There's hoarseness.
Yes po, Doc. Pero the patient can swallow his saliva po, but not water.
The patient can swallow his saliva but not water. Okay. Tongue deviated to the left. Care to elaborate more on this finding?
Doc, pinatanong ko lang po, tapos daw yung dila po ay pag pinalabas po yung dila po na napupunta daw po siya sa left side po.
Okay, you already mentioned your corticobulbar fibers a while ago, di ba? What cranial nerve innervates are nandiyan na pala 12. So paano masasabi kung infranuclear or supranuclear yung tongue deviation ng patient? So para siyang, paano mo masasabi kung upper motor neuron yung lesion sa tongue weakness niya or kung lower motor neuron? But when we're talking about the corticobulbar tract, we use infranuclear or supranuclear? So ano pwede mo sanang natanong para ma-qualify kung lower motor or infranuclear yung lesion? If you remember Jade Moore's table a while ago. Are you there, Frances?
Yes po. Doc, ask po the patient po to move his tongue po if kaya niya pong ma-move yung tongue niya po to the other side po or hindi.
Are you sure? Sige, do you remember Jade Moore's table a while ago? Where he showed an upper motor neuron versus a lower motor neuron lesion? Of course, you can
Doc, check,
yes?
Doc, check po if there are fasciculations po.
Yes, you check for fasciculations. If there are fasciculations, the lesion is most likely
Lower motor po.
lower, but since we're talking about your cranial nerves, infranuclear. Okay? Kasi sa corticospinal tract ginagamit yung neuron, si anterior horn cell yon. Pero meron din siyang homolog sa corticobulbar tracts mo, and that's your cranial nerve nuclei. So pag may fasciculations, meron bang fasciculations? Hindi nabanggit, hindi natanong.
Hindi po nabanggit po.
So if the patient has fasciculation, I think tinanong siya ni Dr. Yagon mo din kanina, di ba? What was their fasciculations? Now about swallowing, kasi swallowing, it's not just a function of your cranial nerve 9 and 10, swallowing. Okay, although 9 and 10 figure prominently, but it's also affected, actually it's also affected by gravity, no? By gravity, but you also need to be awake to be able to swallow well. If your patient cannot understand, pwede din eh, no? We've seen patients who, akala mo ayaw lang nilang uminom, pero hindi nila masabi na nauuhaw sila. Or pag i-offer mo, hindi nila alam, hindi nila naiintindihan. That's why very important yung visual cues dito. If you can, well, we're wearing masks, no? Pero pre-mask era would actually be more exaggerated with our enunciation of words. Tapos may action, no? May visual cues para maintindihan nila. So I'm not convinced actually that the tongue deviation to the left is due to a lesion of your cranial nerve septum. Okay, so it's supranuclear. Motor, so left-sided weakness, a bit decrease also on the right.
Yes po, Doc.
Okay. So mukhang ano to, may old ba siya? May old stroke ba to?
First time niya pong nagkaroon ng stroke symptoms po.
Sige, kasi meron ka din sa right. Because it could be that maybe he's had, nakapiksaban siya. Maybe he's had, I'm guessing, an old stroke before. Was the condition kung flaccid or rigid or yung tone ng muscles niya? Was it mentioned? As?
Hindi po, Doc. Ano dun sa apixaban po, Doc, yung patient was not compliant po. Hindi po masyado siyang umiinom-inom po kasi sabi niya mahal daw po.
Mahal nga talaga. Okay, so mas mahal mas stroke. Okay, so I'm guessing lang based on this, and your patient is AF, so maybe at risk siya for multiple strokes. So he could have had an old one in the past, but he was not able, kumbaga hindi niya pinansin. Also, it would help if the motor tone was elicited. Kasi pag old na yan, na stroke, mas spastic. Kapag new stroke, mas flaccid. Okay, meninges, no pertinent finding. Next. Next slide. Okay, is there a neurologic lesion? Yes, upper motor na eh. Meron kang brainstem, saka cerebellum, posterior lobe. Why? Okay, next slide please. Okay. When we localize, we try to localize, to try to pinpoint the smallest possible lesion that can explain for all those symptoms. So, bakit ka may RPCA at saka may right pica?
Sa PCA po kasi doc, yung patient has homonymous hemianopsia po in the left po. And for the pica po kasi doc, yung patient is may hoarseness po tapos may po siya, dysarthria po.
Sige, babalikan natin. May ginawa ka naman na na concept map bandang dulo. Sige. Okay, so monitor. Sige, next. So where you have two CT scans here, which one is your patient? The one on the right. Sa kanya din tong right?
Sa kanya po yan both po.
Yeah, bakit parang magkaiba sila ng resolution? Kanya din tong right?
Yes po, Doc. Same po.
X-ray kanya to.
Hindi po, Doc.
So ang sa kanya itong buong nasa right.
Pati po yung isa po, lahat po ng results nandito po, sa kanya po lahat, Doc.
Okay. Tingnan mo ha. Tingnan mo yung CT scan niya, fourth row. Okay. Can you describe the fourth row? Kasi kung titingnan mo, na ito yung CT scan niya, pero maghanap ka ng kapareho niyang cut sa baba. O sige, but third and
Doc, ano po, Doc, there are hypodensities po in the frontal and the occipital lobes po.
dun sa fourth row.
Yes po, Doc.
Pero, sorry parang magkaiba rin CT scan to. Kanya daw talaga, pareho?
Yun po, yes po. Yes po, Doc.
Sige. Kasi naghahanap ako ng, although ito, kamukha niya yung nandun sa third row, fifth column. Medyo siya na yung pinaka-malapit. Diba?
Yes po, Doc.
And then, there's a lesion on the right cerebellar area. But it's old. Also in the right occipital. But it's subacute, color-wise. Tapos right frontal. But it's old because it's hypodense already. You actually also look at the lowest row, fifth row. What can you see there? Fifth row, first column.
May hypodensity din po sa frontal lobe po.
Saan pa?
And also on the parietal lobe po.
Diba? Doon sa kanyang mga subcortical regions on the right. On the right side, meron din siyang areas of ischemia. Kikita mo? Itim?
Yes po, Doc.
Where's your arrow? Can you point to it? For the people who are also watching.
What tayo? Ay, nakikita na yan.
Ha? Ayun. Sige, move it to the, meron din dyan actually. Ayan, it's actually just beside. Sige, first column, fifth row, right hemisphere. Ay, left hemisphere, sorry.
Density po dito, Doc.
Okay, on the, what part of the brain?
Frontal lobe po.
Right or left?
Right frontal lobe po, Doc.
Punta ka dun sa left, subcortical area. Left side of the brain, subcortical area. Meron din diyang mga hypodensities. Kita mo?
Yes po, Doc.
Can you hover your laser pointer over them?
This one po, Doc.
Hindi, left hemisphere. Kita mo? Yan. O sige, nasan yung isa pa? Yon, yung isa pa. Tatlo nakikita ko on my screen. Pero actually, look at this patient. Meron ka rin sa right. Actually, multiple. I'm seeing multiple strokes. in this case, so pwedeng first onset of, lesions as far as his memory serves him. But there are actually many old ones. Okay. Red arrow, second row, no? Right cerebellum. Ayan, Pinoy, first column, third row, basilar artery sa gitna. Okay, pointed by your red arrow. Third column, first row, right arrow. Okay, sige. So what do you see? Can you describe this image on the left side of the screen? What do you see?
Doc, ano po, yung sa yellow arrow po, meron pong hyperdensity po. Probably the MCA, right MCA po. Tapos meron po din po sa ibabaw po ng midbrain po, which is the basilar artery po.
Yeah, that's your basilar artery. It's in the middle. Okay. How about this bigger slice on beside the X-ray? Can you just describe again the findings?
There is po on the right side of the brain po, there is a loss of the gray and white differentiation po. Tapos po meron din po may sulcal effacement din. White matter, gray and white matter, ano po.
So there's loss of gray-white matter differentiation. There is sulcal effacement. What else? Giant sulcal effacement. Okay.
Loss of insular ribbon din po, Doc.
Okay. Can you point to the insular ribbon on the other side? Can you point to it? Your insula. Where is it?
Yan po, Doc.
There. Okay. And you cannot see it on the right side. So there's loss of insular ribbon. What else?
Also po on the right occipital lobe po, meron din po ulit hypodensity po.
Okay, hindi siya, di ba ventricle lang? We're talking about the bigger infarct. Anyway, if it's an infarct, it can be an old one because it's hypodense already. We're talking about the bigger one. Okay, so the things that we described, loss of gray-white matter differentiation, sulcal effacement, loss of insular ribbon, what are those? What do you call them?
Early signs po of hyperacute stroke po, Doc.
What artery?
MCA po, Doc.
MCA. So kulang pa nung gusto mo pang idagdag, pero wala siya dyan sa, hindi mo siya makikita dyan sa...
Wala po siya, Doc, pero meron po siyang dense MCA sign po, which is nakikita po
sign.
Dense.
Yes. What can explain for the dense MCA sign?
Yung onset po na ano po ng stroke po.
Yeah. Why does the MCA appear dense? Onset is yes?
May clot po, new onset po na clot, may bagong clot po na nag-form po. Kaya po siya hyperdense po sa CT, on CT.
So may clot or yung blood flow in that area and blood appears white, right? Onset is that. Sige, next slide. So INR is 1.07. When was the patient last apixaban intake?
Yung before po ng onset ng symptoms po, which is 6 hours prior to admission po, Doc.
Nakainom siya 6 hours, just 6 hours prior to admission.
Yes po, Doc.
So actually, kung nadala nga siya ng mas maaga, may less than 3 hours, pwede. Oh. Pasok ka pala sa INR cut-off mo. Sige, pero wala, lagpas na. Sige, next slide. So NPO, so di na siya nakainom. Insert, sige, apixaban, you resumed it. So E4V1 6, patient localizes with the right Okay, sige, next slide.
Second hospital day po, Doc.
Okay. So your target, your BP targets, SBP 220, BBP 120, MAP 130. Okay, total cholesterol 300. Sige, next. So Chad's BAS 4 has bled 2. Ano yung 4 niya? Ano yung Chad's BAS niya?
Diabetes po, hypertension, and onset of stroke po.
So 4 points. Has bled.
Hypertension po and the anticoagulant po taken by the patient.
So ano yung 2 points niya na yun sa has bled?
One po for the anticoagulant po and one for the hypertension po.
Okay, sige. Captopril. Ito, rosuvastatin, Jade Moore, are you there? Yan yung wala sa ano mo, sa report mo. Para saan bang statin?
For ano po, dyslipidemia po since the patient has elevated LDL and total cholesterol po, Doc.
Okay, but in patients who are post-stroke, even if the cholesterol levels are normal, you still continue your statins. Okay.
Yes.
The patient might insist. No? Normal naman, kasi totoo naman that statins were initially just for cholesterol, but numerous studies reveal that statins actually help in stabilizing your atherosclerotic plaques. Okay, so what's a stable atherosclerotic plaque, di ba? Thick yung fibrous cap, maliit yung lipid core. Yung unstable, thin yung fibrous cap, tas malaki yung lipid core niya. So unstable yun. So statins help in stabilizing those atherosclerotic plaques para hindi din mag-thrombose or mag-embolize. Okay? So even if the cholesterol is normal, actually if you're post-stroke, post-MI, diabetic, syempre pag mataas yung cholesterol, post-stroke, post-MI, tapos may calculator which includes age and diabetes as among the variables to be considered. Hindi ko memorize may cut-off siya, but if it's greater than that, you consider giving statins. But if for stroke cases, actually, ischemic stroke cases, we actually give statins. Okay, regardless of the level of cholesterol. Okay, insulin, digoxin, omeprazole, lactulose. Ay, binibigay ba natin siya sa antioxidant, ang lactulose? Why do we give lactulose?
To prevent straining po, Doc, when para to prevent increase in cranial pressure po, Doc. Pero dito po, kasi may nakita po akong journal po, Doc, na ginagamit siya as indirect antioxidant po, kaya nilalagay ko po.
Okay, pero wala dyan yung main purpose niya, which is to just actually prevent straining. Okay? So yung indirect antioxidant, yeah, indirect na, but it's not really, it's only secondary. Okay, so it's really to prevent straining. So we don't give we don't give suppositories, or we don't give labatiba, kasi that will increase your intra-abdominal pressure and transmit to your intracranial pressure. Okay, so we don't give those kinds of interventions to facilitate bowel movement. So we give stool softeners para hindi sila mag-strain. Okay, next slide. Diagnostic CT scan after 2 to 4 weeks. Sige, babalikan natin yan CT scan after 2 to 4 weeks. Next slide. Okay, next slide. Sige, next slide. Okay, so cardioembolic stroke suddenly tend to occur suddenly with maximum neurologic deficit, most commonly in the ICA, MCA, PCA. Sige, next. So here, when's your plan for repeat CT scan in this patient?
Doc,
When's your plan for a repeat scan in this patient?
2 to 4 weeks po,
2
Doc.
to 4 weeks. Okay. If you recall, Dr. Yagono asked, right,
Yeah.
about the 4th day.
Yes po, Doc. 3rd to 4 or 4th
Yeah.
day po.
4th day. You actually monitor the patients for deficits. And if there's new onset deficit or progression, you request for the CT scan right away. But it averages around the 3rd to 4th day. Okay, the maximum edema peak averages, but we've seen 6 to 7 days. We've also seen within 24 to 48 hours malignant malignant infarction. No? But on the average, kaya siya tinanong ni Dr. Yago no kanina, how's the patient on the 4th day? Because around that time, you've actually that's the average time for maximum edema peak. Look here on the right, the increased glucose metabolism in the penumbra, peri-infarct depression like depolarization, biochemical pathways increase volume of infarct. So you've already seen how the infarct looks like on the first day. It's big. Mamamaga pa yun. Lalaki pa yun. So it averages on the 3rd or 4th. So you should ask for CT scan sooner. Okay, in this case. Actually, yung binanggit mo na early signs of stroke, no? So kahit may idea ka na kung malaki o maliit based pa lang dun sa paunang CT scan, no? So malaki, kalahati ng brain, pwede pa yang lumaki pa. Maaga pa, unang araw pa lang. Okay, so you request for the CT scan sooner because of this, increased volume of infarct. Also yan, yung inflammation mo din. Okay, next slide. Ito pa pala. Water influx with sodium, edema. So, edema, inflammation will all contribute to increased volume of infarct. Okay, next slide. Sige, impairment by localization. So, agree. So, what do you call the area that is damaged, producing aphasia? What do you call?
For the broca po. Broca for the
Kasi area, dito pala siya.
yan
Okay.
po.
In this patient, does he have Broca, Wernicke, aphasia, or global?
Global po kasi, Doc, yung may commands po hindi niya po nagagawa po. Pero nung pinapa-perform po, pinapagaya po siya, hindi niya rin po kayang gawin po, Doc.
So unable to understand and speak. So you have global aphasia. Nanonood ba kayo ng hospital playlist? Dami-daming pwedeng mapulot doon na na mga neuro learning pearls. Okay, next. Vertebrobasilar artery. When you still push for that one,
Basilar artery po, Doc.
you will still push for it as your localization. So ang localization mo, MCA. Okay. PCA, homonymous semi-anopsia. Pero bago dumaan, buti na una si Jade Moore na nag-lecture sa'yo. Okay, so he already traced the visual pathway. Remember the visual pathway. So you can have homonymous semi-anopsia in lesions of the occipital lobe. But where else will you see homonymous semi-anopsia? If you recall the visual pathway initially shown.
Sa optic tract.
Sa optic, saan? Are you there, Francis? Mahina ba internet mo?
Hello po, Doc. Sa optic tract po, Doc.
Sa Sa optic tract? Okay, sa optic tract. Sige, optic tract. So, saan ka pwede magkaroon ng homonymous lesions? Optic tract, saan pa? So, occipital lobe, optic tract, saka saan?
May optic radiation po, Dok. Sa
Optic
may
radiations. Tama, optic radiations. Pero kung maliit lang yung stroke mo, just affecting the parietal optic radiation, pie in the ground ka, di ba? Lower quadrant tanopia ka. Pero kung temporal lobe lang, kung saan may special name yung ano doon, optic radiation doon. Sabi ni Dr. Manaras back. Kapangalan niya yung author ng Twilight. Nang tawag mo doon? Mayer's loop. Okay. Mayer's loop is temporal lobe, right? And then you still have your optic radiations, parietal lobe. Nagkasama sila sa optic tract, tapos nagpunta sa LGB ng thalamus, tapos naging radiations na, right? Bago magsasama ulit naghiwalay sila, tapos magsasama ulit sa occipital lobe. Imagine nyo?
Yes po, Dok.
Okay. So you have your occipital lobe, you have your optic tract. But if your lesion is so big, affecting your temporal and your parietal, which is supplied by your MCA, and in this case, the patient's lesion is big, diba? Then you can have a combined pie in the sky and pie in the ground lesion. Pie in the sky, pie in the ground. Pero pinagsama mo kasi affected parehong temporal sa parietal lobe. Diba? So, pwede nating i-disregard si PCA. Next, dito tayo sa basilar artery. So what are these syndromes you're describing? Diplopia. Did the patient have diplopia? Dysarthria? Sige, kasi ito yung pinahahawakan mo lang, no? Cranial nerve 9 and 10, dysarthria. 9 and 10 for dysphagia. Pero tingnan mo, okay, cranial disorders, does the patient have this conjugate gaze? Duling ba siya? O di ba nakatingin lang siya sa isang
Sa right ay sa left lang po nakatingin, Dok.
Oo. So hindi siya ang disconjugate kasi, duling ka. Tapos hindi nag-uusap yung mata mo. So yung isa tumitingin sa kabila. So usually when you move your eyes, yoke yan. So sa disconjugate gaze, does your patient have that? None. Hypoalgesia not tested. Lower motor neuron facial paralysis. What is a lower motor neuron facial paralysis?
Sa patient po,
Ha?
wala na, is central po, Dok.
Central. So,
Central facial paralysis.
So pag central ang facial paralysis, ano ang affected?
Lower half of the face po.
Lower half. Okay, pag lower motor neuron facial paralysis, anong itsura?
Yung left buong side po na affected po yung...
Okay, sige. So parang Bell's palsy yung classic nun, di ba? Buong kalahati ng muka. So wala ka dun sa patient. Di ba? Tapos itong, okay, meron kang naman na-mention na Millard-Gubler, Raymond syndrome, Wallenberg. Okay, do you have this in the patient?
Wala po, Dok.
Diba? Okay, look, Wallenberg, hindi na-mention dito kay Wallenberg. Sensory deficit in the contralateral limb, ipsilateral face, at meron silang ptosis, meiosis, anhydrosis. And yet you mentioned that your patient's pupils were equal. But this patient, in patients with Wallenberg, pica, lesions, makikita mo mas maliit yung ipsilateral to the lesion. There's ptosis, meiosis, anhydrosis. Yun yung trio, no, ng triad sa Wallenberg syndrome. Ptosis, meiosis, anhydrosis. Okay, so hindi mo siya na-mention dyan, but you don't have that in the patient. So if you're going to just to localize, sa local, isa lang. Anong pipiliin mo dyan? Ayun pala, Horner syndrome. Thanks, Dad. Horner syndrome, triad of Horner syndrome seen in Wallenberg. Okay. Horner syndrome, sige. It's due to your affectation of the autonomic nervous system. Again, the nuclei are in your 9 and 10. Sige. Pero dyan sa tatlong yan, kung multiple choice, best answer, saan ang localization mo?
Sa MCA po, Doc.
All of the above. MCA, di ba? Kasi MCA, very, very glaring. Now, if you will push for PCA and BA, then you look for supporting signs and symptoms also. And if you're looking at lesions of the brainstem, magkakalapit yung cranial nerve nuclei mo doon. So makikita mo yung mga affectation din ng other, may makikita ka mga craniopathies. Sige, next slide. Okay. Sige. Next slide. Okay, so yan na pala yung ano mo, chance vast mo. Okay, next. Next. Wait. Sige. When did you resume apixaban in this patient?
The first hospital admission po, Doc.
Right away?
Ay, hindi po. Yung first hospital day po pala. First hospital day po, Doc.
So yeah, on the first hospital day. Okay. What are so before we go to your journals, what are the usual complications of large MCA infarction? So we've already mentioned one a while ago. What was it?
Decrease sensorium po, Doc.
No, complication. What are the things you watch out for? This patient has a large right MCA artery infarction. So what will you watch out for in this patient?
Loss of consciousness, decreased mental status po, Doc.
Okay, due to or secondary to?
Yung due to the edema formation po kasi nag-increase po yung volume po.
Okay, so you can have increase in infarct size. Okay? Increase in infarct size or malignant infarction. So dyan papasok yung sinabi ni Dr. Liago no na that you refer the patient for surgery, can do hemicraniectomy, take off a side of the skull just to let the brain breathe. Okay? What else? So the patient is a candidate for surgery. Right? You're anticipating that in the future. I understand you did not see the case. It's just a paper case. But you don't stop, in real life, you don't stop at day 2. And you anticipate what will happen in the future. So this patient might possibly be a candidate for OR. Nag-start ka na ng anticoagulants. Diba? Ano pa? Pag malaki ang infarct, anong pwedeng mangyari?
Pwede po magkaroon po ng conversion from infarct to
Yes. Pwede siya mag-hemorrhagic conversion. This big. So, nagbigay ka din ng anticoagulant. So, malaki siya. We don't have a repeat CT scan, no? So, we request for a repeat CT scan sooner. In this case, actually. Sooner if with decrease in sensorium kung stable 3 to 4 days. And then, we modify our management. Okay, about as for initiating oral anticoagulants for this size, we don't give it right away. According to the European stroke, ESO guidelines, okay? In patients who were previously on anticoagulant, you wait for 1, 3, 6, 12 weeks before restarting their maintenance anticoagulant. So 1, 3, 6, 12 weeks. So 1 is, pag TIA sa mild stroke, you can already restart within the day. So if this patient, like yung kay Jade Moore, TIA lang yon, maliit lang, or wala nga lesion eh. No? So you can restart your maintenance anticoagulant right away. Okay, kapag moderate, so nakita mo yung infarct ng patient mo, kung mga kalahati nun, mas moderate, you can start in, TIA, pag small stroke, 3 days. Tapos pag moderate, so kalahati nung infarct size mo, you can start it in 6 days, no? Tapos pag mas malaki pa, 12. So yung 12 can be days or weeks. So pwedeng 12 days po. So in this case, if it's that big, I'll restart it at 12 days. But these dates are just arbitrary. Yung 1, 3, 6, 12. You'd still, kasi kung mapasitiskan mo siya ng mas maaga, tapos wala namang infarct, ay walang bleed, tapos lumiit yung infarct, then you can start the anticoagulants right away, no? Tapos yung 12 weeks, may, di ba? 1, 3, 6, 12 weeks. Yung weeks, 12 weeks is 3 months. So in a patient, let's say on anticoagulant and they had the bleed, so nag-hemorrhagic conversion yung patient, we usually wait 3 months before starting, lalo na kung malaki. But in between, so pwede ka naman talaga magpaulit ng CT scan after 4 weeks. Kasi kung wala ka namang bleeding, pwede mo naman nang i-restart. But these are yung 1, 3, 6, 12 weeks, days or weeks na, ano lang yun, estimate, no? Of course, if you have proof naman na walang bleeding or repeat CT scan, you can start it sooner. Or if you deem that the patient has a higher CHA2DS2-VASc score. So for this 4, medyo mataas-taas. Diba? So actually 2 lang, because of a stroke, mag-start ka na. So ito 4, medyo mataas-taas na yung CHA2DS2-VASc mo. You can give it sooner, but in this case, with a big, large main trunk infarct, you don't start it right away, okay? Because there's a propensity for hemorrhagic conversion. Okay, comparison of effectiveness. How did they compare apixaban with rivaroxaban and warfarin? Head to head?
Doc, they compared po the of the elderly patients po taking apixaban with patients taking with with other anticoagulants po.
Hindi siya RCT, tama? So they just see kung sino yung cohort ang method mo, cohort analysis. So they just got parang similar patients with similar profiles na nakadabigatran, tapos warfarin, rivaroxaban at apixaban at kinompare?
Yes po.
Okay, so cohort analysis, evidence hierarchy, hindi siya masyadong mataas. The trial that apixaban is banking its banking its credibility on is the Aristotle trial. Okay, Aristotle, it's RCT. Pero it's it's actually funded by the pharma that produced apixaban or Eliquis, that's Pfizer. Pero RCT yung ginawa nilang trial, Aristotle. Cohort, sige, okay lang naman para pwede, pero in terms of hierarchy evidence, hindi siya as powered as, let's say, meta or RCTs. Sige, next slide. Next slide. So this one, okay, before, yung findings mo. So makikita mo naman talaga, okay, so apixaban is, bakit dito mas maganda si dabigatran? Okay, third, apixaban.
Sabi po, Doc, lower po siya sa sa dabigat ay mas lower po yung apixaban sa dabigatran po. Pero yung statistical significance niya po ay hindi naman po ganong ano po. Hindi po siya ganong significant.
110 na dabigatran o 130 na dabigatran? Kasi dabigatran has 2 doses. There's 110, there's 130. Apixaban is superior to dabigatran na 110. Pero non-inferior siya sa 130 as far as ischemic stroke is concerned. Pero mas superior siya pagdating sa bleeding. No, so you know, when you start your patients on anticoagulants, you always weigh the risk and the benefit of giving the anticoagulant versus bleeding tendencies. So apixaban versus warfarin, actually compared to warfarin, magaganda naman na ang ating mga NOACs. Okay? Next slide. So summary, next. Ay, isa lang ang journal mo?
Ay, yes po, Doc.
Article mo? Hello? Para tayo nag-sesilas.
Isa lang po, Doc. Sorry po, Doc.
Ay, isa lang?
Isa lang po, Doc.
Okay, sige. Anyway, you look up the Aristotle trial. Now, sabi mo this patient is not compliant to his medicine?
Yes po yung apixaban po, Doc.
Yes, mahal talaga siya. Pfizer made it eh. Wala pa siyang generic. So do you have a cheaper alternative to apixaban? You can go 2 slides back. May choices doon. Two slides back, may choices ka doon. Let's say your patient complains. Next slide. The one with the graphs. Okay, the answer is there. Kung namamahalan patient,
Dabigatran po, Doc. Pero nung chinek ko yung prices po nila, Doc, lahat po sila mahal po, Doc.
So ano dyan ang pinakamura?
Dabigatran po, Doc.
No. Twice a day pa nga si Dabigat.
Yung warfarin po, Doc. Tapos,
Warfarin. Actually, before the advent of these NOACs, warfarin was our anticoagulant of choice. Bago-bago lang to eh. Less than 10 years lang tong mga to. Itong mga apixaban mo, I think, is 5. Dabigatan is older. Siguro may 11 years na siya. Then rivaroxaban din. Apixaban is actually the newest here, but we have a new one, edoxaban. Okay. Warfarin is the oldest. But what does warfarin offer as an advantage? So magrereklamo yung patient. Doktora, mahal. Di naman ba ako inom ng gamot o meron ka bang alternative? You can give warfarin. Pero when you give warfarin, what will you advise the patient?
Doc, when taking warfarin po, Doc, dapat po mag-avoid po ng foods, green leafy vegetables po, Doc. Kasi since vitamin K, po siya, Doc. So, wala pong effect yung gamot kapag kumain siya at the same time po ng green leafy vegetables po.
That's why I asked you a while ago in the personal and social about eating Ilocano food. Actually, ang hirap i-convince ng mga kababayan natin because when you agree, when you take warfarin, you should avoid green leafy vegetables. Or if you eat, it should be consistent, no? Pero yun nga, para hindi din tumaas yung dose mo ng warfarin. Okay, so ideally, you have a consistent diet. So hindi ka yung naggulay ngayon. So pag naggulay ka ngayon at naka-warfarin ka, malapot pa yung dugo mo, malabnaw. Kunwari naka-warfarin ka, tapos kumain ka ng madaming green leafy vegetables. Anong mangyayari sa warfarin mo? Ay, sorry, ano magiging effect nun sa warfarin mo?
Yung mas thicker po yung since wala
Okay.
pong effect yung
Okay, and then the next day, nag-diet yung patient. Hindi siya kumain. So, ano mangyayari dun sa kanyang blood this time? Kasi kunwari, kung nakalimutan niya, di kumain siya ng maraming gulay. Tapos biglang naalala niya, hindi pala ako dapat kakain ng gulay. So, how will you monitor the patient's...
Doc,
Yes? Yes, Francis.
Doc, pag pag taking warfarin po, so ang goal po is magiging thin yung blood since may intake po ng green leafy vegetables po, magiging thicker po siya.
Okay. So how will you monitor the patient's coagulation picture? What will you request for?
PPT po, Doc. And
Huh?
check po yung INR ng patient po.
Okay. And what is your target?
$2.5 po.
2 to 3. So warfarin has a narrow therapeutic window. Okay? But so when you give your patients warfarin, you tell them to come back for PTINR monitoring. So until you're able to, tas mahirap yan na titimplahin mo yan sa simula. So patients on warfarin do not have the same dose. Unlike apixaban, dabigatran, and rivaroxaban, they're rather fixed. Si warfarin, may mga iba every other day. May 1, may 2, may 1 yan, may 2.5, may 5, may every other day, merong once a week lang. So titimplahin mo yan. So you actually need patient commitment. So if warfarin is cheaper, face value, mas mura siya. But can the patient, meron siyang non-monetary costs like avoiding vegetables, which can your patient do? Also, can the patient keep coming back for PTINR, especially ngayon COVID, yan babalik-balik. So if you want, you can really push for your NOACs. Pero kung hirap na hirap talaga, okay, a third option is aspirin clopidogrel. Okay, but the patient should be made aware that as far as the protective benefit of aspirin and clopidogrel for cardioembolic stroke is concerned, it's only 1/3 of the protective effect of your anticoagulant. Yung sa'yo anticoagulant, yung kay Jade Moore kanina antiplatelet. Diba? So magkaiba sila ng mechanism. Si anticoagulant mo, where does it work? Are you there, Francis? It was in your slide.
Sorry po, Doc. It prevents clot formation po, Doc.
By acting on
Factor 10A po, Doc.
Factor 10A. Okay, samantalang si antiplatelet acts on your thrombus. Ito fibrin, di ba? Fibrin. Thrombin sa kabila. Okay? So you know na aspirin clopidogrel has a different mechanism of action that is not really the pathomechanism for cardioembolic stroke. But if you just need something to thin out his blood, sige, pwede mo namang i-offer, but tell him talagang hindi to yung pinaka-superior. Pero kung issue niya nga yung pera, okay, isa pang issue with the NOACs though, mahal at wala silang antidote. Unlike warfarin, pwede kang magbigay ng, pwede kang mag-transfuse ng mga coagulation factors mo. Okay, for warfarin, reversible si warfarin. Apixaban, dabigatran, rivaroxaban, mahirap i-source ang wala silang antidote except dabigatran ang meron. Ay, sorry. Dabigatran. Oh, dabigatran at meron. Wait lang don't. Pero, ayun, idarucizumab sa Norma La Union. That's for the bigatran, the antidote for the bigatran. But for apixaban and nivaroxaban, wala pa. Warfarin has an antidote. But it also has a narrow therapeutic window. So yun nga, when you offer, actually multiple choice yan sa patient. A, NOACs, pros, cons. Pros, mahal. Cons, pros, maganda. Is very convenient. Cons, wait lang, sorry. Pros, very convenient dosing, very effective, no dietary restriction, no PTINR monitoring. Cons, there's no antidote for the others. The bigatran has, but it's kind of far. Okay, next. That's option A. B, warfarin, cheaper. Pros. Cons, narrow therapeutic window, PTINR monitoring, dietary restrictions. Okay? C, but equally, medyo comparable sila, no? Basta you maintain warfarin within the therapeutic window. C, antiplatelet. Pros, very safe, easy to source, least bleeding, but cons is not as effective. Okay? Or D, none of the above. Diba? Dun sa patient. So when you actually start your patients, itong patient mo kasi naka-NOAC na, but kunwari, no anticoagulant naive, first time, you discuss these things with them and then tell them to choose. Has to choose one based on their preference, lifestyle, finances, no? You always present pros and cons, okay, when you start patients on anticoagulation. Okay, I think we're done, no? We're done. Dr. Manalo, you're back. You have something to say? Okay na ako, Dan. Wait, Dan. Tercy. Wait lang. Are you online or are you in another meeting? No mic, no video. Okay, wait. I will just ask something. What happened to these patients? Yung kay Jade Moore at saka yung kay Frances. Type mo na lang dito. Basahin natin. So about Frances' case, what happened to the patient? Said patient is dead but remembered fondly. So what happened? Okay, sige. Text mo na lang sa chat group yung nangyari sa patients ni Jade Moore at saka ni Frances. Okay? Are there any questions? Ayan, Jade Moore's patient is press. Okay, TIA din yung una ka naisip, pero press, okay? Ano naman tayo, Frances, Jade Moore, I'm also blinded. Hindi ko to alam. Hindi ako ang consultant in charge. Frances, okay. So what happened to them? Doon mo na lang sa chat group, Dad, sa Viber. Bakit meron kang text na said patient is said patient is dead but is remembered fondly? Sino yun? Buhay naman pala pareho. Okay, sige. Said patient was a former. A Frances patient is a different case. But you were pertaining for this patient, matay umuna sakbay nak iparit nga mga tisaluyot, said one Ilocano, yeah. Actually, mahirap pagbawalan ng mga Ilocano maggulay kasi staple. Yeah, this one is a beloved, is a beloved professor. But Francis' patient is, still alive. May repeat CT scan ba siya, Dad? Oh, right basal ganglia hemorrhagic conversion. Francis, are you still there?
Yes po, Doc.
Given this surprise finding of a right basal ganglia hemorrhagic conversion, how will you change your management?
Doc, sorry po, Doc. Hindi ko po narinig, Doc.
Given this, na-repeat CT scan pala yung patient mo during this admission, he's still alive, okay, but there's now a right basal ganglia hemorrhagic conversion. So how will that affect your management? Now, meron na tayo, yung kay Jade Moore, okay na nakakakita na siya eh. Press, reversible, hypertensive. So okay na, wala na siyang bagong itong patient mo may nangyari.
Doktora, sabihin mo nga yung neurologic status para malaman niya yung anong next step gagawin. Pwede ba yun?
Sige. Tersi, could you type? Sorry, Doc, I'm actually also blinded to this patient.
Okay, it's okay. Pero
Tersi, sorry.
it's better kung malaman ng Francis yung neurologic status ng
Yes
patient.
po.
Okay, thank you. At saka kung may hydrocephalus.
Sige po.
Francis, i-on mo nga yung video mo. Hindi ko nga... Paki-on yung video mo, Francis. Walang ano.
Francis, can you please turn on your video? So we could see you.
Okay. Thank you. So, we're asking Dr. Manalo about the neurologic status of the patient with this new finding of a basal ganglia hemorrhage. Okay? Kasi the ventricles, they may have an obstruction of the flow of CSF, and you may want to know the ventricular size so that you can conceptualize your management, what to do with this patient. Doktora, nagtatype ba si Dr. Manalo?
Yan, ito po ang update on the patient. So the patient is now, on discharge. After how many days, Dad? The patient is awake, dysphasic, already able to follow commands. The forced gaze deviation has resolved. Can already swallow soft diet without choking. With left hemiplegia. And AF is controlled. No hydrocephalus, but with basal ganglia hemorrhage. So there's no hydrocephalus, but with basal ganglia hemorrhage. So how will that change your management, Frances?
Doc, since may hemorrhagic conversion na po yung, yung patient po, ano po yung anticoagulants niya po. And also, address po yung, ng hemorrhagic conversion po ng patient.
Okay. So, 2 weeks yung patient sa hospital apparently, matagal, ganun kalaki yung stroke niya. Ano mga comments dito? The basal ganglia hemorrhage was clinically silent because it was also on the same side of the infarct. Okay, but the speech has improved, the swallowing has improved. Okay. Sige.
Doktora Manalo.
Yes
So,
po.
okay. The initial CT scan showed hemispheric, looks like an hemispheric infarction, and very little on the basal ganglia. So,
Yes po, Doc.
so now there's a conversion on the basal ganglia hemorrhage. What happened to the hemispheric infarction, the blunt infarction?
Yes. Thank you, yeah. How will you address that? Francis. Thanks, Doc. Yeah, we missed that. How will you address the infarction? Malaki. Or paano siya in-address ng team? Kaya nabuhay siya at napauwi.
Medical decompression.
Doc, decompression po, Doc.
How will you decompress it?
I-check po, Doc, if kaya po ng patient na medical decompression po using mannitol po. Or if not po, surgical po. I-refer to neurosurgery po, Doc.
Maski magaling na yung pasyente.
How will you give mannitol?
Doc?
Mannitol.
Doc, hindi po masyadong naririnig.
How will you give mannitol in your patient? How will you give mannitol?
Given po around 175 po, tapos i-paper po siya, Doc.
75. What's your patient's weight? How do we give mannitol? No, is it there? I don't think it's in your slides. Yeah, it wasn't there. It's not there for a very big lesion. So,
Wait po, Doc. Check ko mo yung... Nito, Doc, 0.2 po yung 0.2 grams per kilogram po, Doc.
what?
0.2 kilogram ay 0.2 grams per kilogram po, Doc.
Are you sure? Are you guessing? How do you give mannitol? Sino bang may similar case sa'yo sa chat group? Sino na yung tinanong ko tungkol dyan? Para mag-call a friend na lang tayo. So how do you give mannitol?
Doc, 0.5 to 1.5 milligrams per kilogram po, Doc, since the patient is
So,
ano po.
0.5 to 1.5 mg per per kilogram body weight per ano?
Per
You give
day.
per day, per dose, every how many hours?
Ano po, Doc? 0.5 to 1.5 milligrams per kilogram per dose po every 4 po, Doc?
Yes? Nag-mute ka
Ay,
kasi.
ayan po. 0.5 to na ano po dito? 0.5
Yeah, it's okay.
to 1.5 per kilogram po per dose every 4 to 6 hours po, Doc.
Okay, bumabagyo daw sa batak. So in this patient, what's the estimated body weight? Or what's the body weight?
75 po, Doc.
So 75
So,
times
75 times 0.5 po. So,
you
30.
go with 0.5. Or 0.5 ba? Pag 1, pwedeng point, sige, you can start with 0.5 to 1. But, yeah, because, so that when the edema progresses, you can still increase it to 1.5. Or let's say, 0.5 times 75.
37.5 po.
So, mannitol comes,
37.
manalo dito. Mannitol comes in 20 grams per 100 ml solution. So, how will you give it? So, 75 kilos times 0.5 is 37.5 milligrams. So, how will you give 37.5 milligrams of mannitol? Sorry, grams pala. Sorry. And we're using yung mannitol na 20.
Ano po, Doc? Since 37.5 po ibibigay po yung 40, Doc?
Ha?
Ay.
Okay. It will depend. Sabi dito ni Dr. Manalo, okay, sorry, bumabagyo sa batak. Mannitol comes in 20 grams per 100 ml solution. Okay? And the dose needed is how many grams pala? Sorry, grams. 0.5 to 1.5 gram per kilogram body weight.
Yes po, Doc.
Go by 0.5. So 0.5 times 75 is?
37.5 po.
Okay, 37.5. For every 100 ml solution, you have 20 grams of mannitol. So para magbigay ka ng 35 grams of mannitol, ilang solution ang ibibigay mo? So for 20 grams in 100, you need 35. So ilang ml solution ang ibibigay mo?
Ay, 187.5 ml po, Doc.
187. Okay, kahit 180. Sige, 190. Okay. So after multiply mo lang by 5. Kasi 20, di ba? 100 divided by 20. But if the available mannitol in the hospital is 25 grams per 100 times 4, di ba? So in this patient, if you give mannitol, what will you monitor if the patient is on mannitol? Sige, what's the mechanism of action of mannitol?
Mannitol po is osmotic diuretic drug po. So, kailangan po i-check yung urine output po ng patient po. Input and output po ng patient po.
Okay. So what else will you monitor if your patient is on mannitol?
Check din po yung other blood pressure din po. Urine output. Yes po.
When you give mannitol, there were BP precautions, right? How will you give mannitol? Infusion or bolus?
Infusion po, Doc. Tapos po kasi pag in mannitol po, kailangan po i-monitor yung BP po kasi po pwede po maging hypotensive po yung patient po.
You don't give it as an infusion. You give it as bolus.
Bolus po pala, Doc. Sorry po, Doc.
Kasi pag nag-i-infuse siya doon, what happens is mannitol, okay, mannitol is in your blood vessel, right? So mannitol is there in your blood vessel. If you infuse it, it will eventually leak out, especially in your case na siguro disrupted yung blood-brain barrier in that area, di ba? It can leak out. And then it will still pull water with it. Okay? So you give it as bolus para saglit lang siya dun sa blood vessel, and then it creates there's a concentration gradient, right? You have a higher concentration gradient in that area, so water will flow from area of low to high concentration gradient. So hihilain niya yung tubig, and then how will you excrete it? Through the
urine po, Doc.
Okay, so through the kidney. So you monitor urine output, and how will you monitor kidney function?
Check po Doc. Kreya po ng patient po.
Okay, BU and Kreya. Ano pang ginagawa ng mannitol?
It can lower also po the blood pressure of the patient po. Kaya po nagkakaroon ng hypotension po.
Yes, so aside from blood pressure, ano pang pinapababa niya?
As well as din po sa intracranial pressure din po. Decreases the intracranial pressure po.
Okay, so it lowers the BP, it lowers the ICP. What else does it lower that you can monitor? Sama mo, magpapa-blood works ka na rin for BU and Kreya. Ano pang idadagdag mo?
Check din po sodium, electrolytes din po, sodium, potassium po.
Ano mangyayari sa potassium?
Since nag-increase diuresis po, pwede po mag-decrease yung potassium po, hypokalemia. Mag-decrease po yung
Mag-decrease, okay. Ano mangyayari sa sodium mo?
Mag-i-increase po, Doc.
So mag-increase si sodium pag na-dehydrate ka, di ba? So you also monitor for those things. Okay? So anyway, fortunately, this patient did not have to undergo surgery, though he stayed with us for 2 weeks. Okay, so actually minsan may ganda. Dr. Liago, no, I have a question about early hemi. Is it already early hemicraniectomy? Is it already beneficial? Para hindi nagtatagal yung patient sa hospital po? Ay, sir, wala po kayong mic. Wait lang po. Sir, you're muted po, Doc. You're muted po. You're muted po. Ayun.
What we do is not really early, but it depends on the neurologic status presented to us at the time of consultation. Judgment says that if there will be no neurosurgeon available on that night or tomorrow or something, then okay, go ahead and do a preemptive decompression. Because we have done, I think Dr. Razos has done several, and they do well. except in really late cases where we didn't do it early enough. You know? So right now there's no study, there's no concrete study about when to do it, why you do it, who are the patients that you're gonna do, something like that, who will benefit from it. But definitely it's a life-saving procedure. So that's all I can say.
I think in this case, because the patient did not have a midline shift on admission, at least the initial CT scan. So medyo magandang prognosis na tawid natin ng hindi na ooperahan. Thank God, kasi wala kaming neurosurgeon ngayon, doc, sa hospital. And then we also have to deal with the inconveniences of COVID. But,
Doctora. There is. Yeah, we're doing the old way of doing emergency cases there, right? Able to, if you know what we've been doing for the past 6 years, Dr.
Yes
Ras.
po, Doc.
Ano na lang o sige, alam mo na.
Yes po, Doc. Okay.
Okay.
So, but if this patient presented initially already with midline shift, you might have to consider early decompressive hemicraniectomy. Pero in this case, makita mo maganda pa yung ventricles niya, wala pang compression. So, yeah, here's hoping. Also, when you offer surgery, according as Dr. Yaguno said, it's only life-saving. But would the family be able to afford also taking care, looking after the patient? So it's not just, prolonging the life. It's also quality of life. But we don't decide for the patients. Okay, we offer it to them, and it's up to them whether or not they'll accept a live patient na alagain. Okay, pero some recover naman. Or parang pray plus maximum medical decompression for the patient. So you don't decide for them, let them decide for themselves, and then just offer all options, But in the end, assure them that we'll do our best. Okay? Sige. So Dr. Manalo is always being cut off. Do you have any other questions from the audience, from our presenters? Sige, Francis, pwede ka na mag-off. Pero Jade Moore, gusto kitang makita. Saka ang baby mo, na toddler na siguro ngayon. Hello! Yeah, batang MMMH yan eh. Sige. So, this is how we roll during the pandemic. And the first batch who is so fortunate to have been able to do face-to-face with the patients. So they see how different. Pwede ka na rin mag-off ng video mo, Francis. Closing remarks na lang ito. But this is a paper case, okay? So si Percy, what you ask him, that's just what he'll supply. So kunwari patient siya or informant, nothing can replace a real life actual case. But we need doctors right away. We want to produce competent doctors. So this is how we roll with the pandemic. So puro tayo paper case. I hope madaldal lang ako, maingay, marami akong tanong. Pero yung nung pagtatanong ay kasi we're not having didactics anymore, di ba? Hindi naman na tayo nagka-classroom lessons. You learn from your patients. But since these are paper cases, so parang nangyayari din, discussion na lang siya, di ba? Na para lang maintindihan natin hindi yung kapag nakikita mo talaga na nira-rounds araw-araw, monitor yung BP, yung INO, yung electrolytes, yung pati yung serum osmolality, di ba? So this is how we try to maximize for now. Okay, but let's hope na the pandemic abates soon so that we can already, have actual face-to-face discussions, patient rounds, patient examination, no? Okay, sige. I think we're good. We're done. If you have any questions, the Viber group is open.
Meron ako, Doktora.
Yes, Doc.
Just for 1 or 2 minutes. Okay, I do e-consults of OVP, no? So when they when the bridger, it's a medical student usually, asked me a question, if I can see this patient. I said, okay, take a picture of the patient and then send me the CT scan. So is it possible for you or for Tercy to just a few video or picture of the patient and whether the patient is aphasic, weak or something, and then show it to the medical student who will, or to the clerk who will discuss this case? I don't know. I was thinking about what I do at e-consult. Kanina, meron pasyente, like, the patient is hydrocephalus. Okay, picture mo nga yung ulo, and then give me the CT scan, and I'll be able to decide. So, baka makatulong yun sa mga estudyante while waiting for a face-to-face.
Yes po, Doc. Actually, he's offline na. He's in another meeting kasi kaya he's in and out. But I think what happens, because we're both blinded, Doc, but there's this Viber group. He sends an initial history, and then what they ask for, that's what he gives. Yung video images, sige, medyo may DPA, but kasi sa Doc, pinadala naman sa kayong mga ibang labs.
Okay.
Okay, kailangan ano kasi sa DPA kung may patient, pero we can try to anonymize po. No? Sa hirap nga po, Doc. Hirap.
Yung pasyente, tapos
Neuro exam pa, ang hirap. Kailangan mo ng fundoscopy nga, hindi na natin magawa eh.
Wala yan. Kawawa
Yeah.
ophthalmologist.
Yes po. So pati yung fundo, yun, ang dami hindi natin magawa, no? Heel to finger to nose, kasi bawal. Even asking them to smile, no? Kasi syempre that will entail removing the mask to see the grimace, the tongue, anyway, yun. So we will make do. We'll try our best to make your rotation with us info-pack as possible, no? So medyo intense lang usually mga reporting kasi dito lang naman tayo nagkakausap, no? Pwede din sa Viber group. Pero yung teaching points, yun nga, na-miss ko, buti naalala ni Dr. Yago no yung manitol. Diba? So kung ano lang pwedeng pag-usapan kasi lahat naman ang nakikinig, yung exam ninyo kung ano yung hindi porke yun yung ikaw lang yung nag-report nun, pwede mo siyang i-master, pero makikinig ka din dun sa lectures ng iba kasi hindi naman makikita lahat ng pasyente. So maximize mo yung learning, tapos yung pag-facilitate na lang ng discussion, we do it during this. And if you have questions, the Viber group is open. No? Sinasagot ko naman kayo dun kahit hanggang alas 10 ng gabi. So yeah, we just want it to be very, the discussion, you want it to be very high yield. Okay? Sige, so if there are no more questions, okay, we'll see you again tomorrow at 8 a.m. If Dr. Yago, can you join us? Para may ano ka ata ng Sabado, no? Pero 8 a.m. the next batch.
Yeah, I can book. Yeah, my next vaccination is Thursday, Friday sa Novaliches. Okay na po.
Okay.
Okay.
Okay po, Doc. Pero may e-consult ba kayo ng Sabado, Doc?
Kanina, tapos hindi, Monday, Wednesday, Friday. Pero yung e-consult ko mamaya pa alas 6 kasi ngayon na, malapit. Ay, mag-alas 6 na pala.
Ngayon na po, Doc. Sige po. Well, let's go. Sige po. Maraming salamat, Doc. Let's go. Sige po. See you, everyone.
Okay.
Okay.
Thank you, Doc. See you po.
Yeah, see you again tomorrow.
Thank you po, Doc.
Bye.
Thank you, Doc.
All right.
Thank you.